everyone.
Yes, Saloni, please.
Yeah, thank you, sir.
आपल्याला
Hello, Veena. We'll start at 6 sharp. It's already 6:01.
Sir.
I think we should start. Yeah.
Yes.
So once you give me a thumbs up, then only I will start.
Start.
Can we start?
Yeah.
Yes, yes.
Dr. Girish, sir, we are welcoming you.
Yeah, thank you. Good evening, respected faculty, teachers, and dear delegates. We welcome you for the 11th National Conference of Indian Association of Traumatology and Critical Care. This is our 11th National Conference. So we will start by giving a welcome address by our President, Dr. Sanjay Shah, who is presently the President of Indian Association of Traumatology and Critical Care. May I invite Dr. Sanjay Shah, please, to give his welcome address.
Thank you, Dr. Girish. Indian Association of Traumatology and Critical Care is a specialty section of Association of Surgeons of India, and it was established in year 1989. And from there on, it has moved up quite vibrantly, particularly from 2011. It is conducting annual midterm conference, and this is going to be 11th year of academics and conference. And due to the COVID pandemic, we are conducting this event on a virtual platform. More than 560 delegates have been registered, and about 40 national faculties across India and couple of the international faculties are going to be with us during these 3 days. We are very thankful to our parent association, that is Association of Surgeons of India, President Dr. Abhay Dalvi sir, Secretary Dr. Sanjay Jain sir, and Academic Director Dr. Santosh Abraham. So I warmly welcome all the delegates as well as national faculties who are keen to participate here and dedicate themselves to uplift the level of trauma care in India. So without wasting much time, now I will invite Dr. Abhay Dalvi sir, who would be doing inauguration of this event. Thank you, sir. Over to Dr. Abhay Dalvi sir.
Dr. Abhay Dalvi, sir, President of Association of Surgeons of India, my teacher and mentor to so many students. Sir. Please.
Good evening, everybody. I bring you greetings from the headquarters of the Association of Surgeons of India, situated, everybody knows, at Chennai. This is the 11th annual conference of Indian Association of Traumatology and Critical Care, headed obviously by Dr. Sanjay Shah, the President, and Vinit Kumar, the Honorary Secretary. There are other people to help in this organizing this conference, the Yashoda Hospital from Solapur. And I congratulate the entire program that has been done. I want to suggest something in this talk of mine. We have reached hand transplant as far as traumatology is concerned, and multidisciplinary modalities should come into picture to discuss this aspect of trauma. I'm sure it will in future form a part. Second important thing I would like to suggest to you is, along with physical trauma, there is a lot of mental trauma that also goes into patients. And there should be some part discussed during these conferences so that surgeons who are treating trauma also should know how to give emotional and mental backup, not only to the patients, but also to the relatives. With these few words of mine, I don't want to waste much time. Wish you all the best and for this entire conference. I know I'm the first chairperson, but I have requested Dr. Girish Bakshi to introduce speakers. I will be there, but possibly I will be driving, so I may not be able to concentrate too much. So wish you all the best and best wishes from the ASI headquarters. Thank you.
Thank you very much, sir, for those kind words. Thank you very much, sir. Now, I invite Dr. Abhay Dalvi, sir, ASI President, to chair the first session with the theme of Panoramic View of Trauma. I also invite Dr. Sanjay Jain, sir, who is Secretary, Association of Surgeons of India, to please kindly be a co-chair for this session.
Girish sir, inauguration video.
Yeah. We'll start with the lamp lighting.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं
Thank you for playing that music. So we start with the first session. I invite Abhay Dalvi sir as the chairperson, Dr. Sanjay Jain sir as the chairperson. The theme is Panoramic View of Trauma. I'll introduce the first speaker, Dr. Sanjay Shah, who is presently the president of Indian Association of Traumatology and Critical Care. He's a senior trauma surgeon and a consultant attached with Apollo Group of Hospitals, Ahmedabad. He has been director of Apex Academy and he has received V. Ramamurthy Govind Medal.
क्या हो गया? हाँ, मैं कॉन्फ्रेंस में आया हूँ.
Girish, can you see the slides?
You have started sharing, but your slides are still not seen.
Okay. Let me share.
Yeah, now your slides are. Can you go on the slideshow mode?
Yeah, please.
Yeah, now it's seen.
Yeah.
Please start.
Yeah. Thank you, Dr. Girish, for a kind introduction. We'll be going through another 20 minutes for trauma care, the current Indian scenario, what is the current status in India as far as trauma care is there. So I will be going through the incidence of trauma in India, particularly last 20 years, the trauma center and importance of having trauma system, importance of trauma training, and what are the challenges and the way forward, what are the options we have. Such kind of incidences are quite common nowadays on highways as well as expressway, and whether it is a public transport system or private vehicles, these are the scene which are happening very commonly on as a high-speed motor vehicle crashes. Even the ambulances are also not exception into it, and sometimes it is because of the opponent's mistakes, or sometimes the rash driving of ambulances also. We do have road traffic accidents. We all know that India has quite a significant number of population, and same is true as far as traffic system is concerned. It is quite complicated in nature because of much of the indiscipline in driving, as well as overspeeding, drinking and driving, avoiding safety gears, and in spite of multiple reminders from the media that we are having much of the discipline than what we should have. It's like in one of the article from Ahmedabad, it is like 380% rise in using the mobiles while driving. So this should be absolutely avoided. In India, whatever the data, published data we have, in 2014, nearly 1.39 lakh people died in road accidents. And in next year, in 2015, which it showed that rise is nearly 5% yearly. And it is like if we divide it in a per day, it's a real, literally around 400 people who are getting died per day. And if we equate it with any other episodes, like this is like nearly plane crash every day happening. Even if it happens once in a while, then also media as well as community that they feel very sad. Now this is happening daily, and then also we are not doing much for prevention as well as making our system efficient. And this is increasing from 2008 to 2017 nearly by 23.4%, and nearly 17 deaths happening every hour, which is taking more than 50% of the life, which are ranging from 18 to 35 years of age. These are very active, dynamic, and earning people of the society and country, and we should not lose them. And deaths due to other modes of injury like railway accidents, assaults, factory mishaps, falls, riots, natural and man-made disasters are not yet counted in this. And there is some of the component of underreporting as well. If we subdivide from the state-wise, Maharashtra tops for road traffic accidents, followed by Tamil Nadu and Madhya Pradesh. And if go by cities, then Mumbai has the highest number of road accidents happening, then followed by Delhi and Bangalore. Now, this slide is very important. This shows the total number of deaths due to any kind of injury per year. And if we see here, decade-wise, from 1970 to 80, it was ranging from 1 lakh to till 2010, which was going up till 3 lakh per year. But now, from 2011, if we see even yearly, this is going nearly 4 lakh and above. And that's how we are showing, we are having increase in the number of deaths due to any kind of injury. I do not have much of the data here, but it has gone up. Number of the deaths per lakh population per year from 18% to 32%. And obviously, if we go through this data, probably we have gone up to 40 per year per lakh. Road injuries cause 65% more disability, early deaths in 2016 compared with 1919. That's what the article which was published in Indian Express 2018. So such kind of print media also, shows alarms, but we are not much aware or rather keen to improve our level of trauma care. A percentage share from various causes of accident deaths, which was in 2013. If you see, the road traffic accident is taking nearly 35% of the death. And then there are various other causes as mentioned before. we were of impression that China must have more accidents as well as mortality due to higher population, but it is not the fact. Rather, India has more road traffic accidents and more fatalities from 2005 onwards. If we see here in 2005, India was having less number of road traffic accidents as well as less number of deaths per year than China. Then China has significant improvement due to the preventive programs and significant reduction in road traffic accidents, as well as significant reduction in mortality due to accidents. While India is escalating quite high, nearly by 5% every year, reaching on a higher side than China, and there is significant difference between the two in spite of higher population in China. Yes, that is not the true story. The government of India is also making certain aspect of improving level of trauma care. Nearly 140 trauma care facilities or trauma care centers are there in government hospitals along the Golden Quadrilateral Highway that is under the scheme of National Highway Trauma Care Project, which is ranging from more than 5,800 kilometers connecting from Delhi to Kolkata to Chennai to Mumbai to Delhi. At the same time, from north to south and east to west corridor, which is covering 7,700 kilometers, connecting from Kashmir to Kanyakumari and Silchar to Porbandar, respectively. So this is the quadrilateral highway and the number of trauma centers, as well as from north to south and east to west, again the number of trauma centers. But these are not just sufficient enough the way we have a number of road traffic accidents as well as the other accidental causes. So what we need to understand that we have what we I showed here is number of the deaths and number of accidents which are happening, which is just a tip of an iceberg. Some of the injuries which are resulting in hospitalization, that is also quite reported. But what is less reported or underreported is injury resulting in visits to the emergency department, which are trivial enough or smaller enough, does not mandate hospitalization, and injury resulting into the visits to the nearby primary healthcare facilities, as well as may not be going to the healthcare personnel at all. So these are the significant number of injuries which are not reported or underreported, and that is a significant burden on the society as well as country. So what's the way forward? Uh, Other than the preventive aspects, what I can talk about is pre-hospital care and in-hospital care, because the preventive aspects is more with the government authorities than healthcare facilities. So when we discuss about pre-hospital care, we should have robust and universal pre-hospital care, that is EMS system across India. Now, emergence of 108 emergency services, emergency ambulance services has been available to more than 17 states in India, which provides BLS as well as ALS kind of ambulances, which are quite good equipped ambulances with a trained manpower. But they should be trained for first aid, basic life support, advanced cardiac life support, as well as pre-hospital trauma life support, with a good command center with proper documentation and audit to improve the level of pre-hospital care in India. Now, what is now alarming from this article from Guru Raj is we have about 35% of mortality which is happening at scene, and about 11% of the mortality was happening due to the pre-hospital delayed transport or delayed pre-hospital care, and about 53% of mortality was happening in hospital, and post discharge there is not significant data which shows that what is happening after patient is being discharged at home. But now, because of good pre-hospital care which is happening due to 108 arrival in most of the state, these are the burden of pre-hospital deaths which is going to come to your hospital, and it is going to increase the burden of the trauma patients in our hospital. And if we are not making our system quite efficient, we might become graveyard of these trauma patients. So what is the need of an hour? We require efficient trauma system at all tertiary care hospitals, whether it is public and private, in all tier 1 and tier 2 cities. Yes, we have multiple trauma centers. They should continue to provide trauma care along with academics and training of doctors and paramedics, which can be deployed to such hospitals. ATLS training shall become mandatory, and we have about 19 ATLS sites in India, and Dr. Winston will be talking about detail in about ATLS. Trauma team should be announced once we know that trauma patient is coming in your hospital by activating the trauma code. Trauma surgery should become a specialty. Trauma is more in rural than urban areas. Not many surgeons in tier 2 cities for trauma care, and super specialists probably practically not available. We have more focused approach like subspecialty to genetics to molecular level, but unfortunately, no one is there for holistic care of trauma patient in emergency department. So that's why emergency physicians and surgeons should take the lead, and they should be trained in trauma care in various subspecialties like neurotrauma, orthopedics, plastic, reconstructive surgeries, and vascular and thoracic surgery. They should be trained to become team leader, and they should have a good exposure of mass casualty and disaster preparedness. They should be trained to deal with the worst clinical scenario and to cope up with any kind of demanding situation, working in orders with a less number of staffs and resources. Yes, for those who are surgeons, DSTC is a very good experience. That is definitive surgery for trauma care, which gives you animal lab experience for improving trauma care. But now, as of now, it is not available in India. He should be a owner of the patient, which requires proper coordination with other specialty and managing the priorities together. Should not get carried away with the distracting injuries. Reevaluation, and reevaluation should be an important aspect to identify any hemodynamic deterioration while treating trauma patients early in emergency department. Efficient management of non-algorithm injury is also important because many times injuries may not be a like book picture when with the proper algorithm of that particular region. You may have polytrauma and complex injuries. And that's how dynamic decision-making process is important with where the priority can change suddenly. So one should lead from front, right from ER till death or discharge. And hereby, I want to give just one real example. Patient who is a 11-year-old boy. He was playing, fell on road, metallic road, and had injury on the left side of the neck with a severe bleeding. He was taken to a nearby small surgical capability hospital, where surgeon tried to control his bleeding with after applying hemostatic forceps, which he couldn't, and patient was deteriorating, so he was intubated, IV fluid was started, and patient was brought to a tertiary care hospital. In ambulance, he was accompanied by anesthetist as well as surgeon, and just before arrival of the patient, he had arrest. In ER, we continued with resuscitation, CPR, continued, rhythm came to normal. Family was counseled with a very high risk of surgery, poor prognosis, as well as uncertain neurological outcome. We rushed in OR, order for massive transfusion protocol, and intraoperatively, there was injury to the left IJV, left extracarotid artery with the facial artery avulsion. Ligation of the left facial artery was done with a primary repair of left EC and IJV. Post-operatively was kept on ventilatory support with induced hypothermia to prevent further hypoxic ischemic brain damage. 6 PCVs were transfused, 4 FFP and 4 platelets were given, and patient was extubated after 48 hours with a very good neurological outcome. What we had after surgery that blood reports showing hemoglobin of 2.6, INR 4.6, PS 6.92, and BICAP of 11.5. And this is the picture of the same boy after 3 to 4 days in the war, and he was about to just get discharged. So this is what we can do. A surgeon usually fixes the anatomical derangement, intensivist fixes the physiological derangement, but trauma surgeon can fix the both right from ER till patient goes into the OR and ICU. So what I urge is one should have the ability as team leader in any demanding situation, get help, involve required specialty together and early in the course than late. Be very receptive. Training of emergency physicians and nursing staff is key for successful outcome of trauma patients. Closed loop communication. Please do good documentation because it is very important. All these cases are medico legally important. and hence communication and documentation is is required. One should have a model for disaster preparedness as well whenever it happens. To 50% of the missed injuries are reported even after primary survey and secondary survey. And it should be, that's why the tertiary trauma care survey should done within 24 hours after admission. And it's repeated when the patient has become conscious, responsive, or able to communicate. It should be done by senior trauma surgeon and with a complete review of physical findings, radiological and laboratory data. What there are certain challenges ahead in private practice. Most of the time awareness for trauma care is lacking. At the same time, in public sector, it is, there is enough workload, it is quite huge, and there is scarcity of manpower, and that's how the outcome is not that great. Trauma education program like FNB and MCH at very few institutes in India as of now, but yes, of course, in last 10 years, there are multiple sites which started this kind of academic programs. We do have certain social life challenges, and hence to avoid them, one should have a team approach to overcoming. Try to make miracles more frequently and dedicate yourself for trauma care in such a way that institute makes a habit to call you in worst scenario. To summarize, what we should have is good, efficient, and robust trauma system, which has a preventive measures, pre-hospital care, in-hospital care, right from emergency department, which has a resuscitation bay, various priority areas like priority 1, 2, and 3, 24/7 availability of OT and ICU, blood bank, pathology and radiology wing, and that should be a coordinated trauma team all the time available. Yes, of course, we should not forget to have a good post-hospital care as well as rehabilitation to make them independent as far as their pre-injury aspect is concerned. So they should be able to do the work whatever they were doing before injury. Education and research is very, very important, and disaster preparedness also should be there, and mock drills should be carried out to have better outcome in disasters. So I will end my talk here by saying this because I love this slide. As trauma surgeon, I don't believe in just miracles, I rely on them. Thank you for patiently listening.
Thank you, Dr. Shah. That was a wonderful presentation, giving the overview of the scenario in India. Good evening,
Sir,
everybody.
please stop your share. Sorry, share.
Now, may I invite for the second talk, Dr. Winston Narona, to brief us about the ATLS principle.
Okay. Okay. All right. Yeah. Fine.
Hello.
Yeah, the
Okay.
slides.
हाँ त्यांचे नाव काय आहे?
Good evening. Yeah, Girish, can I start or you're introducing the?
Yes, sir. You can start. Please start,
Okay.
sir.
Yeah. First and foremost, I thank the IITCC for inviting me to speak. And these are going to be some of the principles that are going to guide us in managing trauma patients. Now, the principles of your initial assessment are that it should be quick, rapid. Our resuscitation is with an aim to save life. We are not trying to be organ specific, we're trying to save life. We must repeat it often. We have to prioritize and decide finally whom to transfer and when to transfer. So when we look at the overall patient management, preparation is very important. And this preparation is both before and in the hospital. Apart from preparation, we need to know about triage and communication. Then comes the primary survey, which is the ABCDE, which we'll be dealing with in more detail. We resuscitate the patient with certain adjuncts. Then we decide on transfer, especially if we are in a smaller hospital. Go ahead then with the secondary survey and adjuncts with along with the secondary survey.
Hello, Dr. Vincent. Sorry, I'm interrupting your slides. Your slides are not seen.
Oh, they're not seen?
Yes, yes.
No, 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 no.
Okay. Now are they seen?
No.
No.
Okay, 1 second. Just a minute.
Veena?
Just
Uh,
see.
Can the event management start? Sir, do you request, should I request them to start your slideshow?
1 second, just a second. I'll re-put the slideshow on. 1 second. Because I had, yeah, 1 second, just a minute. Just 1 second.
Sure, sir. No issue.
Yeah, just 1 second. Yeah, 1 second, just a minute.
You have not started sharing, Dr. Winston.
Yeah, no, I started, but it went off, I think. 1 second, again, yeah. Now,
Yes.
can you see the slides?
It's still black. It is
It's
Now-
coming up.
showing that.
Yes,
Yes, yes. Now it's
You can
seen.
see, fine, fine. Okay,
Please go
fine.
ahead.
So I'll skip the slide because I'm already, 1 second, I'm not able to go to the next slide. Just a minute. It's stuck on this.
Sir, what you can do is you can stop share and again start sharing. Then it will go.
Okay,
You can
fine.
stop share and then again start sharing.
Yeah, fine. Okay, I'll just share it again. Now, can you see it? Can you see the slide?
Yes, now we can see it.
Okay, fine.
Just start your show. Start.
No, it's not moving. Why? I don't know. 1 second. I'll just try it again. 1 second.
So can we play from our side?
Yeah, you played from your side.
Yes.
Because yeah, played from your side.
Yes, sir. Yes.
Yeah.
These are certain technical glitches, which I think, which is something which we face in our virtual conferences. So,
Yeah.
So as we sort out this problem, I would like to welcome Dr. Sudeep Sarda and Dr. Manik Guru, our MMC observers for this today, for today's conference.
Yeah. Is it opening? Yeah. Okay, fine. Yeah, make it full screen. Yeah. Can I continue? Next.
Yes, please. Yes,
Yeah.
please, sir.
Yeah, next slide.
Next slide,
So-
please.
Next slide, please. Next. Yeah. So next, I finished this. Next. Yeah. So the first thing, when you get many patients is what is called triage. In the case of mass casualties, triage is necessary, and mass casualties are when the number of patients overwhelm the hospital capacity. So we have to sort out and prioritize the patient as per the available resources. As you can see in this picture, there are different color codes: red, yellow, green, etc. Next. So what is this red? Red is the patient who is horizontal. That means he's not able to get up. He's lying down. The ABCD is seriously affected. This is a life-threatening condition. For example, the airway is blocked, or patient's got a tension pneumothorax, ventilation is affected, patient is actively bleeding in shock. So these are the patients who are labeled red and who are treated first. Next. Now the yellow is the next. These patients also are horizontal. That means they're not walking, but they don't need immediate care, but they don't have an immediate threat to life, but they need the next treatment. For example, long bone fractures, spinal cord lesions, abdominal injuries without shock, vascular lesions, and large areas of burns, about 20 to 60%. Next. The green are the walking wounded. Now, these are the people in a mass casualty who are going to be complaining a lot, and they take a lot of resources if you go and look after them. They are the minor injuries, as can be seen in the slide. Next. The blue, or called black or gray, these are the patients who are dead or dying, and these are the ones with unsalvageable injuries. Next. So what do we do? First, when we have a lot of patients, we have to remove the walking wounded, that's the green. You ask all those who need immediate treatment, come here. So those patients will run and come to one area, isolate them, then see the patients who have the ABCD affected, that is the red patients, And after they have been dealt with, go to those patients who have serious injuries but who have an intact ABCD problem. And lastly, then you would be leaving the blue alone. Next. Now, when a patient comes to you, a single patient comes to you, what do we do? So this is the basic principle that we go through this ABCDE approach. A stands for the airway and cervical spine control. Cervical spine is either controlled by a cervical collar or an inline immobilization. B stands for breathing and ventilation. C is the circulation, but remember, you cannot resuscitate the circulation without stopping the bleeding. D is disability, which stands for neurological disability. And E is the exposure. Expose the patient completely, but at the same time, remember, you have to prevent hypothermia. Next. So what's a quick and simple way to assess the ABCD? Just ask the patient, what is your name and what happened? If the patient can respond to you, that means his airway is patent, unobstructed, his breathing is fine, he's got enough circulation to perfuse the brain, and there is no neurological disability. Next. So what are the initial steps in A? Now, first thing we do is we clear the oral cavity, suction the secretions and blood, remove any broken teeth, do a chin lift or a jaw thrust maneuver, which I will show you in the next slide. Give oxygen by mask. Usually it's about 11 to 15 liters. And we assess the need for a definitive airway. If airway is a difficult airway, please call for help. There is no role for heroism. Attempt intubation only twice. If you cannot get in 2 times, please go ahead with a cricothyroidotomy. The alternative methods may include a laryngeal mask or a tracheal tube introducer. Next. This is a basic maneuver where a chin lift is done with 1 hand or a jaw thrust is done with 2 hands. You can see the person with the blue gloves providing the cervical stabilization. Next. So when do we intubate a patient? Whenever there's an airway problem, that is the airway is compromised, or the patient needs a ventilation, that's a breathing problem, or the patient is unable to protect the airway, that is a GCS of 8 or less. So this tells you when do you need to intubate the patient. Next, that's a definitive airway, which is a cuff tube in the trachea below the vocal cords and connected to a source of oxygen. So in order to do an easy intubation, first you need to have a inline stabilization, do a drug assisted intubation as far as possible. Clear the oral cavity as already mentioned, visualize the vocal cords and use the burp maneuver, which is a backward, upward and rightward pressure to easily visualize the vocal cords. Next. Remember, once you put the tube, you got to confirm the tube in an emergency setting. It may not be easy. If you place it under vision, look at the chest movement and do a 5-point auscultation. That may be enough. But sometimes it's always good to use a carbon dioxide detector like a capnograph or an EtCO2 monitor. Pulse oximetry is also useful. If the tube is in the esophagus, one will need to remove it and re-intubate. Sometimes the tube will go onto the right side if it goes in too much. In that case, slightly withdraw the tube. You never take an X-ray to see the position of the tube, but when we take an X-ray for something else, say for a chest problem, and you see that the tube is too much inside, please adjust it. Next. Remember, surgical airways are always cricothyroidotomies, no tracheostomy in an emergency, except in children or if there's a laryngeal fracture. A cricothyroidotomy can be a needle or a surgical. A surgical is better than the needle, but a needle can be used in a life-threatening situation. Next. So after stabilizing the airway, we come to breathing. We come to breathing. Breathing, when you look at the neck and the chest. Look for distended neck veins, deviated trachea, and subcutaneous emphysema, both in the neck and chest. In the chest, we look for the movement of accessory muscles, any open wounds, paradoxical respiration, fast breathing or diminished chest movement. Palpate rib fractures and subacute emphysema, percuss for dullness or hyperresonance, and auscultate for absent breath sounds. There are 2 important things one must never forget is muffled heart sounds. Many times when we auscultate the lungs, we forget to auscultate for the cardiac sounds. Next. When do we need immediate intervention? One is when there is a tension pneumothorax. You need to put a needle in the 5th intercostal space, just anterior to the mid-axillary line in adults. or in children, it's the second intercostal space in the mid-clavicular line, and this is followed by an intercostal drain. In open pneumothorax, where there's a sucking wound, one has to use a three-sided seal. The chest tube is not put in the wound. Next. What's a tension pneumothorax? This is a life-threatening emergency where patient will be in shock with respiratory distress, distended neck veins, and deviated trachea. The breath sounds are absent on that side, and there is hyperresonance. Immediately put in a needle and follow it up with the chest tube. There is no role for X-ray. It's a clinical diagnosis. Next. An open wound like this will sucking wound constitutes an open pneumothorax. If you put a dressing over it and close it completely, it will become a tension pneumothorax. What you do is put a three-sided dressing, leaving one side open. Chest tube, as you can see in the pictures, put away from the wound and can later repair the wound. Next. What's a flail chest is when more than two ribs are broken at two or more places. The segment will move in opposite direction. That's called a paradoxical respiration. Start the patient on oxygen. One of the most important things is to give good analgesia to the patient, as can be seen in the slide. Judiciously give fluids, don't over-infuse. Some patients need intubation and ventilatory support. Next. Now, massive hemothorax is when there's a lot of bleeding in the chest, more often seen in penetrating trauma like stabs and gunshot wounds. There is more than 1,500 ml of blood loss. Patients will be in shock, absent breath sounds, and dullness on percussion. But the neck veins will be flat, not distended, unlike in the tension pneumothorax. Next. So what one does is you may take an X-ray, insert an ICD, lot of blood will come out, so autotransfusion can be given in these cases. If the initial drainage is more than 1,500 ml, or after the initial drainage, more than 200 ml comes every hour for the next 2 to 4 hours, patient will need to have a thoracotomy. Remember, when there are large amounts of blood collected in the chest, a retained hemothorax and so loculated collections are known to occur, and these may need VATs. Next. So where do we put the intercostal drain? In trauma, the ATLS principles are to put it in the fifth intercostal space, just anterior to the mid-axillary line. Remember, go close to the upper border of the lower rib. Finger is used to sweep around into the pleural space. A number 28 or 32 size tube is usually used posteriorly and superiorly. It's indicated when you have an intercostal drain indicated in pneumothorax, in hemothorax, flail chest, and multiple rib fractures, needing positive pressure ventilation. Next. What's a cardiac tamponade? A cardiac tamponade is a collection of blood in the pericardial space, which constricts the heart. It can be diagnosed by Beck's triad, which consists of muffled heart sounds, raised venous pressure, and lowered arterial pressure. Confirmed by FAST or echo. What do you do immediately? Put in a needle under ECG monitoring and aspirate the blood. That's only a temporary measure. The treatment is thoracotomy. Next. Now we have stabilized the A and the B. Now we come to C, that is the circulation. Remember, the commonest cause of shock in trauma is bleeding. But there are other causes in trauma like cardiogenic shock, neurogenic shock, obstructive shock, and later on septic shock. Next. So the first thing is we need to stop the bleeding. When we are shifting patient from the site of injury, compression of the bleeding area, a pressure dressing, a use of a tourniquet, splints for limb fractures, pelvic binder for pelvic fracture. And once the patient is in the hospital, patients can also undergo angioembolization and stenting. Next. So this just pictures show you a pelvic binder which has been applied or a splint for the lower limb. Next. So these measures are done before shifting the patient to the hospital itself. In the hospital, how do you recognize the patient is in shock? Alteration in level of consciousness, cold, sweating skin, tachycardia, tachypnea. Remember, hypotension is seen only in class 3 shock. That's why it's mentioned in the bottom. Never look at hypotension for shock. You must pick up shock before hypotension. Next. So how do we manage shock? We put 2 large bore IV needles, ideally number 16, start 1 liter of crystalloid solution, rush it over 20 to 30 minutes. At the same time, one has to find the source of bleeding. X-ray chest, X-ray pelvis, and fast are done. CT scan with or without an angiogram is only done in stable patients, not in unstable patients. Remember the old dictum, 1 on the floor and 4 more. Next. How do we monitor patient's response? By coming back of the skin warmth and capillary refill, improvement in urine output, improvement in vital signs and level of consciousness. By that, we divide patients into rapid responders, transient and non-responders. Now, in these patients who are going to respond, depending on their response, the further management is decided. Next. When do we give blood? Whenever we start the IV line, we send blood for grouping, cross-matching. In an emergency, one can give type-specific uncross-matched blood or O negative, but remember in India, O negative is never readily available. Blood is transfused quickly when you're not going to do surgical control. For example, a pelvic fracture or femur fracture. But if you're going to do surgical control, it's ideal to quickly control it surgically and then transfuse blood. Next. So ABC is over. Now we come to D. A brief neurological examination consists of the following: the Glasgow Coma Scale, pupillary inequality, and localizing signs. As can be seen in a Glasgow Coma Scale of 13 to 15 is mild head injury, 9 to 12 is moderate, and 3 to 8 is severe head injury. Next. So the adjuncts which are done, I've already mentioned about X-ray, chest, pelvis, and fast. ECG monitoring and pulse oximetry is important, as also is the ABG. In selective cases, we can do an X-ray of the cervical spine, cross-table lateral view. If one is doing a CT of the brain, a CT of the cervical spine can be included. Foley's catheter and nasogastric tube are passed to the patients in order to decompress the stomach and monitor the urine output. Next. What's the aim of our resuscitation? The aim of the resuscitation is to maintain oxygenation and volume. Secondly, to evaluate the site of injury, locate the source of bleeding and control it, and remember at all times, prevent further damage. Especially in head injury patients, secondary injury is more a problem. So we have to prevent further damage. Next. In the second, after the primary survey is over and patient is stabilized, we go for the secondary survey. First is the ample history, as can be seen in the slide: allergies, medications, past illness, pregnancy, last meal, events, and the environment. And this is a detailed head to foot examination of the patient. Next. Remember, the spine board is a transportation device, and the spine board should be removed as early as possible, ideally within 2 hours. Cervical collar also is kept during transportation and removed as soon as cervical spine injury is ruled out. Next. Whom to transfer and when to transfer? If there are complex injuries, multi-system injuries, there are comorbidities, in extremes of age, in short, when the institutional capacity is exceeded, one will transfer, but only after airway and ventilatory control, and ideally after hemorrhage control. Next. So in summary, one has to manage an individual patient by the ABCD approach: resuscitate and stabilize. The whole aim is to maintain volume and oxygenation. Adjuncts are done, which have been mentioned, which are both for monitoring as well as for treatment. After the primary survey is over, one goes to the secondary survey. One has to also decide about transfer of the patient, because if you are, many of you will be in smaller hospitals, in rural areas, one has to realize that transferring doesn't mean just putting an IV line and shifting patient. Transferring is to take care of the ABCD and then transfer the patient. Remember, a living problem is better than a dead cert. Next. Thank you very much for your patient listening, and sorry for the hitch in the initial part of the slides. Thank you.
No, sir, excellent presentation, Vincent, sir, as usual. There is a question from the delegate. When during initial resuscitation, will you prefer normal saline or ringer lactate, or both are equal?
Yeah, we prefer ringer lactate. There are some reports saying that normal saline may cause some hypernatremia, but usually the preferred fluid is ringer lactate in the as per the ATLS. Again, previously it used to be 2 liters. Now they have said give 1 liter and evaluate the patient.
Yes, 1 liter. That was answer the next question, because the next question was what is the maximum amount of fluid to be given in shock before initiating massive blood transfusion?
Yeah, because in children, we give 20 ml per kilogram body weight as one bolus, follow it with the second bolus, and then decide on blood. So remember, today the threshold for blood transfusion has been lowered. Okay, so it's not like we go on giving fluid, because the compartment syndrome danger is always there.
Yeah. It was a very nice presentation. Can you display the thank you slide, Veena? Thank you, sir.
I request Dr. Girish Bakshi to kindly introduce the next speaker.
Yeah. Speaker is my friend Dr. Sandeep Jain, who is a consultant trauma surgeon at Super Specialty Hospital, Max Super Specialty Hospital, Saket, New Delhi. He has done his fellowship in trauma care, and he is also faculty of ATLS of American College of Surgeons. And he'll be speaking on missed injuries. Dr. Sandeep Jain, please.
So you can share your screen now.
Yeah, sure. Okay. Thank you, Dr. Girish. So I'll be speaking about the missed injuries. As we have learned till now, that management of a trauma patient is time dependent and involves a quick and rapid assessment of the injuries and their treatment. But in spite of all these clinical and diagnostic advancements, the missed injuries still remain to haunt the trauma department, and this causes a lot of problems further on. So I'll start with an example. This was the case of a 35-year-old male patient who met with a road traffic accident in outside hospital, and 12 hours later he was referred to us for blunt abdominal trauma with hemioperitoneum that was picked up on the ultrasound. On examination, patient was conscious and oriented, and he was hemodynamically stable. But when we re-examined the patient and did the X-ray of the patient, we found that the patient had got multiple rib fractures on the right side associated with lung contusions. And if you look at the X-ray, there was a widened mediastinum. So we subjected this patient for further contrast NRCT, and we found that there was a pseudoaneurysm of the arch of aorta. So this was a blunt aortic arch injury. And therefore, our management now from the management of human
Dr. Sandeep, can you speak a bit loud on your mic adjustments, because people are not able to hear you, please?
Can you hear me now?
Yeah, we can hear you. Yeah.
Okay. So when we looked at the CT scan, we found that there was a pseudoaneurysm of the arch of aorta, and therefore the treatment now got prioritized towards the arch of aorta injury, and the patient was subjected for intravascular stent placement before the management of a liver injury. The second case was a 46-year-old male who again met with a road traffic accident and was referred to us for management of maxillofacial injuries. He was hemodynamically stable, and again on re-evaluation we found that the patient has got lung contusions with bilateral hemothorax and rib fractures, in addition to fractures of the vertebra, the dorsal vertebra. So both these cases just show that how a injury which becomes very apparent is being given a priority, and the injuries which can kill the patient is being missed. So what are the missed injuries? They are very common in polytrauma patients. They have their own clinical and medical-legal problems. When they have a clinical adverse outcomes, this can lead to medical-legal problems and the subsequent lawsuits. The incidence in the literature of the missed injuries have been ranging from 1.9% to 39%, depending on what definition of missed injuries or has been called as a delayed injuries has been taken into consideration, and also on the subject population. It has been shown in the literature that about 1 to 2.3 missed injuries have been found for every patient. And out of this, there are 22%, almost 15 to 22% of the clinically significant injuries which were missed. So when we look at what are the definitions, there's no single definition of a missed injuries. These are the various definitions which have been given. The first one and the most common use is one, the injuries which have been identified after your primary and the secondary survey. The other definition includes the patients who have been admitted to the ICUs. The third definition says that the patient who has not been picked up in the first 12 hours after the emergency department presentation is called as a missed injuries. Or this could be the injuries which have been found after your complete assessment and diagnosis, even after you have done the initial workup. Injuries which were missed are called as missed injuries. Then there were the injuries who were initially missed but detected only after they developed the clinical symptoms. And the last one was the injuries which were detected after discharge from the hospital. So looking at what is a delayed injuries, these were the injuries which were detected after the initial resuscitation, but before the clinical symptoms have developed. They have been also said that after the initial resuscitation, if the injuries were missed and they were uh, they were diagnosed before the discharge from the hospital, they have been called as delayed injuries or a missed injuries. While the clinically significant injuries are those which were associated with a high morbidity and the mortality, requiring any additional procedures or a change in the alteration in the therapy, just like in my first case where we have to change our treatment protocol first, and then the injuries which are leading to significant pain, complications, or disabilities. So if you look at this definition, there are a lot of overlap, and that is why there's a lot of variation in the reported incidences. When we look at the missed injuries, they are also very important when we talk of a quality performance indicators of a trauma system, and that is why we should be looking at this. So when we look at which are the patients where it is likely to be missed, they are usually the patients who are unconscious, patients who are having a multi-system trauma, or the patient who are hemodynamically unstable, because here the whole focus is on resuscitating the patient, saving the life of the patient. And many a times these are the patients who will under sedation or maybe intubated on ventilator, so clinical symptoms might not develop. Otherwise, so basic understanding says that these are those injuries which normally would have been diagnosed in alert and awake patients, because the patient can then present the symptoms. This could lead to appropriate clinical investigations, diagnosis, and treatment. So when we look at what are the injuries missed, there are various regional injuries which can be missed. Looking at the chest as a region, the commonest injuries which are mixed are the rib fractures, because the rib fractures are not easy to be detected on a X-ray unless you specifically look for it, or the rib fractures which are there on the anterolateral sides can be overcrowded or can be overlapped by soft tissue injuries. So until you look for them, you might miss them. Occult pneumothorax or hemothorax can be easily missed on the initial chest X-rays, so you might have to look out for that. Pulmonary contusions have a very nasty reputation of developing later on. Normally, pulmonary contusions does not present early, and so if the patients have been discharged, possibly they may come later, 6 to 8 hours later, with the breathing difficulties. Blunt aortic arch injuries is something which has to be looked into specifically. So the widened mediastinum in a chest X-ray is one of the greatest indicators. Whenever the patient is you're suspecting on chest X-ray, specifically looking for the mechanism of injuries, like the patient who has met with a road traffic accident at a high speed, or the patient who has fallen down from the height, possibly because the deaccelerating injuries have been subjected to blunt aortic arch injuries. Diaphragmatic injuries are not very common in brain trauma, but yes, they are common in penetrating injuries, except especially in the left side, because right side is covered by the diaphragm. So what we get on the X-rays is when the left side of the diaphragm is higher than the right. Normally, we know that right side of the diaphragm is higher, but if your left side of the diaphragm is higher than the right, or you may see that there could be an air bubble in the left side of the chest. This could possibly be a diaphragmatic injury. External fixtures again are very important injuries which are missed, especially the injuries which have got a frontal focus, especially the external wheel injuries. And if you do not do a proper X-rays, it is very difficult to find them, especially on the AP X-rays, because you can't see the sternum. You might have to employ your lateral films or the CT scans. Esophageal injuries again are the injuries which until you look for it, like a patient who comes with a pneumomediastinum, you have to look for the esophageal injuries. Looking for the abdominal part, bowel injuries are the one which are usually missed. The solid organ injuries like liver, spleen are usually seen because we can see the hemoperitoneum. But if you're looking at the bowel injuries, which are not perforated or which have got a small perforation, patient may not develop the signs of peritonitis early. So you have to specifically look for them. Colonic injuries are the injuries which are missed later on because of mesenteric tears. The mesenteric tears which are transverse in their dimensions are more likely to jeopardize the blood supply of the colon and can present later as a colonic ischemias. Pancreas and duodenum, because of the retroperitoneal origin, are likely to present late, and if the patients, because we were not taken good care of the patient's mechanism of injury, there's a possibility that these retroperitoneal injuries can be missed. Ureteric injuries are usually associated with other competing injuries like injuries to the IVCs or injuries to the kidneys. So you have to specifically look for the ureteric injuries. Genital injuries, because of possibly hesitation to look for the genitals at the initial examination findings, might be the other injuries which can be missed. So musculoskeletal injuries are the major group which are missed because they usually do not kill the patient, but they increase the morbidity. They constitute almost up to 50% of these injuries. Usually the small bones of the hands and the feet are involved. Ligaments and tendon injuries are notorious to be missed out if you have not been specifically done the clinical examination, and especially if the patient is unconscious. It's very difficult to diagnose. Peripheral nerve injuries in a unconscious patient is not examinable, so you have to wait for the patient to wake up and then you examine the patient so he becomes cooperative and allow you to examine the nervous injuries. Vascular injuries in the presence of a previous atherosclerotic disease or previous peripheral arterial diseases are the injuries which can be missed easily. If there's a frank discrepancy between the two limbs, the pulse is not present, it's easy to diagnose. But if there's a small discrepancies, like if you try to look for ankle brachial index, that can give you a hint regarding the vascular injuries which might be there. Compartment syndrome is something which all the patients who have met with a multi-system trauma has to be specifically looked at, because the patient who is unconscious, patient is on sedation or maybe intoxicated, might not be giving a pain. And even though there is not much injury which can be seen on the surface, because of the internal injuries, patient may develop compartment syndrome. Another important injury is internal degloving, or what we call the Mora Lava lesion. So there is a complete dissociation between the soft tissues and the skin, and the bleeding can happen within the skin. The skin might not become necrosed initially, so the patient may develop all the sepsis leading to myoglobinuria and renal failures, and there could be foreign bodies. So musculoskeletal injuries are the one which are commonest missed. When the focus is on treating the life-threatening injuries, these small injuries, especially if they are put up on the plasters or on the bandages, are likely to be missed. So look for them whenever we have a specific injuries.
Dr. Sandeep, can you be a little bit time because we are running out short of time.
Sure.
Thank you.
So then we have a craniospinal injuries like the traumatic brain injuries, especially in the elderly because of the atrophy. On oral anticoagulants can have injuries because of minor traumas. Cervical, thoracic, and lumbar injuries, especially those which are stable injuries, or the injuries which are the C1, C2 junctions or the T7 junctions. So those injuries can be missed. Carotid and vertebral artery injuries have been missed very frequently because you have to specially look for them. The injuries which are blunt injuries through the neck, look for the carotid and vertebral artery injuries by doing investigations. Otherwise, the patient may develop a stroke or neurological symptoms. So what are the factors which affect the missed injuries? Are the patient factors, provider factors, and the environmental factors. The patient factors include the altered consciousness levels, hemodynamic or respiratory instabilities, or the distracting injuries, because the patient might not be able to perceive the pain from the minor injuries as well as what he has perceived from major injuries. Higher injury severity scores, paralysis, sedations may be the one in which the patients have more likely to have it, missed injuries. Delayed presentation of the injuries or the delayed presentation of the patients who come to the hospitals after a delayed intervals is another important cause of missed injuries, while the injuries at hidden areas like scalp in the genitalia or the axilla are not specifically looked for. Looking at the provider factors, this is an important part because we need to have experienced trauma care providers who can especially look for these kind of injuries. If you have not completely examined the patient, if you're not being following the ATLS protocols, or there are multiple care providers with a loss of communication between the numerous handovers, these can lead to missed injuries. Inappropriate, inadequate investigations or delayed referrals. We have seen this many times, especially in the peripheral centers, when all the investigations are being done, and then the patients, after the investigations, are referred to a higher center. By that time, a lot of physiological derangement has happened. Environmental factors are very important again because we do not have in India the uniform infrastructure. If the facilities are not available, the doctors might not be able to pick up those injuries faster. There could be technological limitations like inadequate imaging or delayed imaging. Radiologists, especially in the nights, might not be well experienced, and so injuries might be mixed. Another important part I want to put out here is whenever you are sending a patient for investigation, please give the history and what you are expecting, what injuries you are expecting to the radiologist so that he can specifically look for it. If there is a splints and bandages, the radiologist might not be able to do a good examination. Then there are operational issues like lack of manpower or a fatigue. I came across a very good acronym called HALT, which is hungry, angry, late, and tired. So if your team is HALT, then everything would be halted, and you're more likely to develop this, trying to miss the injuries. Then there could be hesitancy on the cost. Social and cultural factors again are an important factor, because if you are working in a center where there are a lot of attendants inside your ED, then you are likely to miss. You're likely to be more, you're likely to be missing these injuries faster. So how do we prevent these injuries? You need to have a high index of clinical suspicion. Give special emphasis on the mechanism of trauma, because most of the mechanism of traumas are associated with a characteristic set of injuries, and you can look for them. For example, if a patient has fallen from the height and is on his feet, you know there is a calcaneal fracture. So the patient may have associated femur fracture or lumbar spine fracture, so look for them. Do a repeated clinical examination, adhere to the protocols. If you adhere to the protocols, you are less likely to miss the injuries. Use investigations wherever possible. Use CT, MRI, or CT angiography to look for occult injuries. There are certain tools which can help you out. This one is called the trauma care checklist, which has been given by WHO. So if you look at it, there are certain checklists which has to be filled up after the primary and secondary survey, and then before the team leaves. So this gives a comprehensive assessment regarding the patient's injuries, the top to bottom examination, patient need for immunizations, tetanus, for antibiotics, or what is the handovers, like what kind of injuries you want to hand over for a further examination. The other thing is what we call as a trauma tertiary survey, which Dr. Sanjay initially given in his talk. So tertiary trauma survey is nothing but a complete review of the patient's clinical status, radiology, blood test results, and the procedures by a team-based review. And normally this should be done by a person who was not initially in the ER, along with the team of the patients who were in the initial phases. So this should be unbiased reviewer. And because the majority of the injuries are missed by the musculoskeletal injuries, it is better to have an orthopedic surgeon in the team. All the patients should be screened within 24 hours of admission. Use a checklist after the complete resuscitation, and you will find that you're not going to miss the injuries. So this is one example of a form of a trauma tertiary survey from the US. So it gives you complete review of the patient history, his past medical histories, his medication histories. So you do a complete examination and look out for all the injuries. And then it also reminds you about looking at the patient's need for restarting home medication, what we call as medical reconciliation. Look at all the investigations which have been done and review them. Look for the consultations, specialty references which have to be given, and then try to find a new findings and then update the problem list. So once we follow this tertiary trauma survey, which is done after your primary and secondary survey, you're less likely to miss the injuries. Another important thing which we're using is a whole body trauma CT scan, which quickly scans your head, cervical spine, chest, abdomen, and pelvis within 10 to 12 minutes. It is used for faster time to prevent need for reimaging and can reduce the missed injuries. But higher radiation is a concern. But now with the advent of higher size multi-detector CTs using the whole body CT scans where they prevent the overlap scans, the radiation doses have been found to be comparable to the conventional selective imaging. So I'm not saying that you use whole body CT scan all the trauma patients, but a selective patients where repeated shifting of the patient to radiology suite or repeated movement of the patient.
Dr.
Just
Sandeep,
finishing off.
Can you just be fast? Thank you.
Okay, so another important thing what we can do is, if the radiologist misses this injuries initial reporting, second radiologist can report it. Consequences can be a higher cost, increase in the hospital length of stay, increase in the morbidity or permanent disability. If you have missed intracranial injuries or intra-abdominal injuries, there could be increased mortality. So challenges remains the lack of trained trauma care providers for which the ATLS is working for it. Absence of clinical audit system in majority of the hospitals is the one where we do not know our faults and we can't work on it. So it's preferable to have an audit system in the hospitals. There's a disparity in the distribution of resources, and delayed reporting of the investigation is again in addition to absence of the senior trauma care providers in the night. So I would like to conclude that missed injuries are potentially avoidable. You need to have a high index of suspicion, specifically looking for the mechanism of injury. Missed injuries should be identified and treated early and should be audited for the quality improvement, not for the reprimand. Adhere to the trauma protocols and the development of the systems. Repeatedly do your clinical examination with liberal use of imaging, and in the ATS protocols, apart from the primary survey, resuscitation, secondary survey, include the tertiary survey in a standardized format, which can help you minimizing the missed. And thank you so much for your attention. I'm sorry, Dr. Grish, for overshooting my time.
Okay, thank you, Dr. Sanjay. Sandeep, very good talk, excellent talk. There are certain questions I think you can answer on the chat box because we're running short of time, like internal gloving injuries and all those. Please answer them on the chat box. Thank you very much. May I call Veena, can you share the thank you slide? Thank you, Dr. Now I will request Dr. Sanjay Jain, Secretary ASI, sir, wanted to speak a few words on behalf of ASI. Yes, sir.
Just it was a very nice session, very informative, not much of the questions, and it was all expected with the experienced speakers like Winston and the Sanjay Shah. On behalf of the ASI, I would like to congratulate not only the Association of Traumatology and the Critical Care, also the Yashodhara Hospital Solapur for organizing such an excellent conference. I wish all the success. The success is on the board. I can see more than 250 participants just at the beginning. Thanks for inviting me and giving me opportunity to be part. Thank you and wish you all the best. And over to Dr. Bakshi for the next session.
Thank you very much, sir. So we thank Dr. Abed Ali, sir, and Dr. Sanjay Jain from ASI. Thank you very much. We'll start with the next session. The theme is specific trauma scenarios. I would like to invite the chairperson, Professor Dr. Madhuri Gore, madam. She is a consultant surgeon and former professor and chief of surgery at LTMC Sion, Mumbai. She is also the first course director of FNB Trauma. Madam, welcome.
Thank you, Dr. Girish. We'll begin the second session. And
yes, madam.
It's my great pleasure. Hello. Yeah. It's my great pleasure to invite Dr. Russell Gruen. Hello, Dr. Russell. After medical graduation, Dr. Russell did PhD on delivery of surgical services to remote community in Australia. He then, as a specialist trauma surgeon, was affiliated to Royal Melbourne and Alfred Hospital, Monash University. His commitment to injured led to his alliance with WHO and contribution to development of Australian trauma registry, as well as trauma system in different countries. At present, he is Vice Dean at Singapore Lee Kong Chian School of Medicine. And I'm happy that he's going to share with us his secrets of successful trauma system. Dr. Russell, please.
Thank you, Dr. Gore. May I share my screen? I'll share my screen now for you. There we go. And thank you for your warm welcome. And it's such a delight to be with you all. Many friends across the entire Indian continent. I have recently actually returned to Australia, where I'm Dean of the College of Health and Medicine at the Australian National University in Canberra. And this is my workplace and my home. I'm going to, well, if I can, how do I, there we go. We have just finished a very significant decade, the decade of action for road safety, in which there was a major global focus on the development of trauma systems. It started particularly in 2009 with a major conference in Rio de Janeiro, where I met a number of the people who have made significant progress in trauma systems. Many of them were from India. And it was a very significant meeting. This is Etienne Krug, the head of violence and injury prevention at the WHO, who hosted the meeting. And amongst others, Manjul Joshipura was there. And Manjul, of course, became the head of trauma and injury at the World Health Organization for a number of years where he championed the development of trauma systems across the globe. I want to focus on what it is that makes a successful trauma system. Of course, it is not just what happens in hospital. It's not just what happens before hospital, and it's not just what happens after hospital. It is the entire system put together that spans the journey of the patient. And when it works well, it prevents those who could die from dying. It maximizes recovery and minimizes the disability of survivors. And the system itself is affordable, sustainable, and continually improving. What trauma systems provide, and this was what was very simple, pithy language created by the WHO Global Alliance for Care of the Injured, is firstly life-saving care at the scene, secondly timely treatment of injuries, and thirdly restoration of function and independence. 3 phases. It sounds very simple, and in concept it is very simple. It's putting it into reality that, of course, is the complex and difficult part. So I want to take you through a successful trauma system. I'm going to focus on my original home state, the state of Victoria. And this is a book that I wrote on the history of the Victorian state trauma system and how it evolved. And it is a long story. These things don't happen overnight. It's not as though you can change what happens in your hospital relatively quickly through development of new protocols, new systems. If you're the boss, you can tell people how they're going to care for the next patient. But the evolution of a statewide or countrywide system does take considerable time. And this story tells that story, which was a 40-year journey for the state of Victoria. Of course, Victoria is this small red state down at the bottom southeast corner of Australia. Most famous, of course, for the MCG, which you see on the right side here. And unfortunately, this is the way the MCG looks at the moment, empty. We are in lockdown. We have been enduring lockdown for many months. There's actually a cricket game going on here, but no audience, as you will see. And this is the way things are in Australia at the moment. We're finishing our football season, and most of the games have been played throughout the season without crowds. It's quite a bizarre thing. The MCG, for those of you who've been there, is a very impressive stadium where it has people in it. It's even more impressive when there's nobody in it. And this is what it looks like. And just to kind of show you, of course, Australia and India are great rivals on the cricket field. And that competition obviously extends to other things. Well, here's our competition in COVID cases. And the purple line is India's spikes, first, second, third wave. The green line, Australia's first, second, and third wave. And we've just overtaken you in terms of numbers of new cases per population. So this is a battle that is ongoing for both teams. And of course, Victoria has other things that you'll be familiar, but I put this up to emphasize the fact that we are quite a rural country, and even Victoria is quite a rural state. And in a rural state, road traffic fatalities are common, especially so in the 1960s, when, as you know, Australians have a reputation for big drinking. And in the 1960s in Victoria, there was a famous thing called the 6 o'clock swill, which was when people would leave work, they'd all go down to the pub and they'd drink a few and then they'd go home to their families. And way too many people drank too much and died and didn't make it home in their cars because they crashed their cars. And so road trauma fatalities have been the major focus of the Victorian state trauma system right back from when it started evolving in the 1960s. And the 6 o'clock squill doesn't exist anymore. You know, people don't, it was banned for a while and people can still go to the pub, but people don't do that to any of the same degree that they used to. But it was the recognition of that as a major public policy problem that kicked off the development of a world-class trauma system. And just to show you what I mean in terms of scale, this is the absolute numbers of deaths on the Victorian roads since 1952 right through to almost the present. And in 1969, there was 1,034 deaths. Oh, sorry, this is moving backwards and forwards. 1,034 deaths. Now there is less than 300. And it's been a series of public policy interventions that has led to most of that reduction. It's compulsory seatbelts, random breath testing, red light cameras, what we call booze buses, that is breath testing and drug testing on the roadside, speed cameras. But significantly in 2001, there was a post-crash response system, the Victorian State Trauma System, that was implemented. And once that system was implemented, the likelihood of anybody dying after a road traffic fatality was reduced by more than half. There are very few interventions in the world, in any field of medicine, that have been that effective. Within 1 decade, everything else being the same, all injuries being the same, you are less than half as likely to die from the injuries you sustained because of the care you received through an organised trauma system. So let's just unpack that for a minute. Whoops, sorry, this is flying around for me. At the same time, improvement in functional recovery was taking place. So it wasn't just patients who had died became highly disabled survivors. It was actually everybody's outcomes were improving. And it was occurring at less cost per patient. So the system actually was cost effective as well as saving lives. Professor Keith Willett visited Victoria in 2013, and he was the architect of the national trauma system in the UK. He modelled his system on the state of Victoria's system and complimented Victoria on the care and the lessons that are provided for the improvement of trauma care worldwide. So what was it about this system that was so successful? Well, the essential components of this system were three main things. Firstly, a significant lead public agency with the legal authority to establish and enforce trauma system policy. Secondly, the designation of particular hospitals to provide 24-hour medical services for injured patients. And thirdly, pre-hospital field protocols for identifying critically injured patients who required direct transfer to a designated trauma hospital and who wouldn't be well served if they went to a regional hospital that wasn't specialist in trauma. In the story of the evolution of a new system, it was clear that there were several stages to how it evolved. And I want to take you through those stages. The first, the genesis of the system, had three particular steps. Firstly, recognition that road traffic injury was a public policy priority. Secondly, what we call the ABC of trauma care, not airway, breathing, circulation, but absolute budgetary certainty. The ability to finance a system where care had to be provided first and payment might come later. And thirdly, the idea that there is preventable mortality because of the care patients are or are not receiving. And the fact that the public, at least in Australia, found that intolerable, that patients died when they didn't need to. This was the kickoff at the end of the 6 o'clock swill and the start of the Victorian State Trauma System. There's a front page picture in 1970 on the major paper in the state of Victoria of 1,034 children lying on the road in a country town in Victoria to depict how many patients died on the road the year before. It was an editor of a newspaper that started the campaign, and every day for three months he put on the front page of his newspaper a story about road traffic fatalities and young, mostly men, being killed unnecessarily. It was his own war on 1034. But what it did do was kick off 30 years of public advertising around injury prevention, road safety, and messaging that is on the roadside, on televisions, at the MCG, around the sides of the ground, everywhere that we look. In Australia, in Victoria particularly, the public is aware that injury is a major policy priority, and you don't have to convince them. This created an important foundation for change because it was acceptable to the public to do something to improve the care of the injured after the road traffic fatalities. They would give up other things to be able to afford this care. The second piece was to be able to have a system of financing which would underpin urgent treatment of patients without you even knowing whether they could afford to pay or not. And that it wouldn't put the burden on the ambulance service or the hospitals if they weren't able to pay. There were several attempts to bring this in. The first few did not work, but the Transport Accident Commission, which came into existence in 1985, has endured and endured very well. It's a public insurance system funded by a registration fee, a levy, on every motor vehicle in Victoria that pays for the entire healthcare needs of anybody injured in a motor vehicle crash, whether they're a driver, pedestrian, passenger, even if they're drunk, even if it's a stolen car. It's a no-fault injury insurance system where the lifelong care from the moment an ambulance arrives through to long-term disability care, if necessary, is provided from the funds of the TAC. It's been a very successful system. It's been well invested and has a robust corpus that will fund trauma care into the future. It's also been able to fund trauma research because obviously as an insurer, it is interested in lowering its costs. And so investment in improvement in the system and research to underpin that improvement has been incentivized in the system itself. And you can see that of all the claims that go through the TAC, about 16,500 a year, almost all of them are small fry stuff. There are some hospitalised claims amounting to about 1/5, and of the total, only about 3% are the really serious injuries that cause a very severe financial burden on the Transport Accident Commission. But it treats all of its clients the same, and it provides them case managers, and it coordinates their care And so it is really a high quality system. So that was injury being a public policy priority, there being a system of financing that could underpin the development of a new system. The third thing that was critical in the development of the Victorian system was the spark or ignition for change. A surgeon at the Alfred Hospital named Frank McDermott convened during the 1990s for an entire decade a multidisciplinary panel to review all deaths on the roads in the state over several years. It was an interesting get together of emergency physicians and surgeons and anaesthetists and rehabilitation specialists and so on. And they get together for pizza on a fortnightly basis, and they'd go through all the patient notes of every patient that died, and they'd ask the question, could this death have been prevented? And were there problems in the care? And if there were, what were those problems? It is still probably the biggest single death panel audit that's ever been conducted, and it lasted for an entire decade. And what they found was that 30 to 40% of the deaths they examined were preventable or potentially preventable. And that throughout the course of the decade, that percentage did not change, even though they thought that they were improving care and taking note of all the problems they were identifying in the system. What that led to was when it came out that nothing had changed and that many hundreds in the end of patients were dying potentially unnecessarily, not because of the terrible crash they'd had, but because they didn't get the care that they should have got from the health services that should have been able to deliver that care. And so there was some high-profile media things like headlines like "Patients die after errors at hospitals" that came out of this work. And those were headlines that nobody liked to see. The public didn't like to see it. The doctors and the medical profession didn't like to see it. The government didn't like to see it. And so it was a very strong way of aligning everybody's interests to mobilize for change. And so what you had by the end of the 1990s was the perfect situation for a revolutionary change in the way trauma was treated in the state of Victoria. You had an aware public, you had a payment system that could afford to underpin the change, and you had a publicity framework in which there was a political need to do something. And that's what spawned a ministerial review and then support to push through the change. And that ministerial review is now really a foundational document for trauma care in Victoria. It specified in it the lessons that were coming out of the West Coast United States during the 90s about organised trauma systems. And it created a hierarchy and an organised structure in the state for improvement of trauma care that reported directly to the Minister of Health and had a state trauma committee designated in legislation with a whole lot of functions. Sorry, okay. Another big part of it was to designate trauma hospitals, and there were 3 for the whole state. Okay, the Alfred, Royal Melbourne and the Royal Children's, that many of you will know those hospitals and will have visited them. And of course, as we said before, it's about providing life-saving care at the scene and delivering the patient to the right hospital in the shortest time. And because Victoria is a relatively small state, sort of the size of Tamil Nadu or something like that, a helicopter was an incredibly useful vehicle for bringing people from the roadside to the helipad directly in one swoop, so to speak, rather than via smaller peripheral hospitals. So patients could get the urgent care they needed if they really needed it. It changed what happened in our major trauma hospitals dramatically. And you can see that just over the course of 10 years, the number of trauma patients trebled to the major trauma service at the Alfred. Now that's a good thing. That means the system's working, it's getting patients there in time, but it put an enormous strain on elective surgical care at that hospital, to the point where they had to completely redesign the surgical services capabilities and had to, and sometimes actually prevent elective surgery from collapsing altogether, with surgeons walking out because their cases kept getting bumped and cancelled by emergency trauma patients coming in. So these things, you can elicit change over time through system changes, but you need to be ready for the consequences as well. The system showed that it was working, but it has continued to evolve. Since 2010, we've had significant changes to the system with additional monitoring and improvement and the need for flexibility and adaptability. A key part of it has been data collection. The Victorian State Trauma Registry is one of the most comprehensive trauma registries in the world. It's run by Monash University. It's enshrined in legislation. It provides the reports to the State Trauma Committee and the Minister. It provides the data on all trauma patients statewide with follow-up, not just at the end of their hospital stay, but after they've left hospital at 6 months, at 12 months, at 24 months, at 36 months, and now at 5 years. What we get then is a picture of what trauma does to people and the burden of injury that follows after discharge. And this is some of that data. And I guess it doesn't come as any surprise, but when you've actually got the information there, it tells a very, very different story to what you can tell to politicians or to people who can shape the system with hospital alone data. So here we are, only a quarter of patients had a complete functional recovery 2 years after their injury for major trauma patients. Only three quarters had returned to any sort of work. 20% were still in moderate to severe pain. And between 20 and 40% had moderate to severe disability on their mental and physical health scores. Right? So this is a previously unrecognised burden of injury long-term down the track after injury. Important for people who are paying for systems and providing that long-term care to be aware of those care needs. And here's a typical character. Of course, as I said before, as an insurance company, there's an incentive for the TAC to improve the care that's provided and to do the research. So we've actually had quite a lot of money put into research in trauma care because it was going to improve the system and therefore reduce the costs of the insurer, which is the government insurer. And so it is a self-perpetuating system with continuous quality improvement built into the incentive structure of the system. So to come back to where I started, successful trauma systems prevent death when possible, maximize recovery and minimize disability, and are sustainable and continually improving. They provide life-saving care at the scene, they provide timely treatment of injuries, and they provide restoration of function and independence. They evolve through stages. They don't have to evolve all in this order, but this is what happened in Victoria over a long period of time. Firstly, the public becomes aware that injury is a priority. There has to be in place a funding system, in our case, a vehicle tax, that underpins the cost of healthcare provided urgently, where care has to be provided up front and payment can come later. There has to be data to give a reason for change, an impression that there is a better way of doing things than what is currently provided. And there has to be a political window for change. When that window arrives, key stakeholders, that is, government, the profession, the public, perhaps others, need to be aligned in the direction. And then there needs to be continuous data to monitor and demonstrate the impact of change and to provide the basis for continual improvement. And as the system evolves, things do change. With upfront care in Victoria, the number of patients who had truly preventable injuries and who died from hemorrhagic shock, for example, dropped to almost zero over the course of a few years. And so in fact, preventable deaths were very, very low. And so the actual burden was much more of the long-term head injured and spinal cord injured patients on the public purse. And so the focus of the system changed to the management of head injury and spinal cord injury and less about the management of hemorrhagic shock and acute injury up front. As I said, many people from India have had major input into the evolution and development of high quality trauma systems across the globe. Manjul is one, but there are now many others in India. And I had the great fortune to work with many of them through the Australia-India Trauma System collaboration. That collaboration, like every good idea, started with a meeting of bright colleagues. And so here is, at the same Kuala Lumpur meeting as Manjul was presenting, a photo of three of the brightest minds, I think, in India, and a very young me. But these people have been very responsible for the improvement of trauma systems across India. And I'm sure you are aware of who they are. I just want to correct the record here that this is not Assistant Professor Vineet's beer. He was not drinking on the day that the rest of us were. Of course, the Australia-India Trauma System collaboration was a partnership between the Indian government and the Australian government. And Amit Gupta and Professor Mishra and I successfully obtained funding to launch a program, and it was Prime Minister Tony Abbott that launched the program at AIMS in 2014. And it has been, apart from a very successful program of research activities where we've been aiming to see if there are lessons from high income settings like Victoria that can be learned and put in place in India. Apart from that really rich program of research, it's also been a very rich program of friendship and collaboration. And I'm deeply indebted to all the people that I've met through that program in India and the friendships that we have made. I'm sure it's underpinned some great things that lie ahead. Here's just another photo of the launch of that program. And as I said, it's about, doesn't matter whether you got helicopters or whether you're on the street with vehicles, high performing trauma systems can exist anywhere. It's a matter of diligence and focusing on the principles and using what you have at hand. So it's been a thrill speaking with you today. It's been, as I said, a great privilege to work with so many of you and your colleagues on this program. And I'm always indebted to the wisdom and brilliance that trauma doctors in India bring to the world. Please feel free to reach out to me at any stage. This is my email address at the Australian National University. And thank you, Dr. Gore, for the privilege of speaking.
Thank you, Dr. Russell. Your talk has been an excellent learning experience. And I hope that someday, with our young enthusiastic trauma surgeons like Vijay and Vineet taking interest, we will reach somewhere near where Victoria has reached. The long-term load of disability is extremely alarming, and I suppose that in our country it would be even more, but we simply don't have data. But if we can have a task force for COVID, I'm sure we can have a task force for trauma care as well. Thank you very much. There is a question from Vineet about how to go about collecting robust data.
Thank you. Vineet, so there is already some very good registry data being collected in India with a number of different centres participating together over many years now into what has been a very good Indian trauma registry run out of Mumbai by our colleague, what's his name in that photo? I've just forgotten it for a minute.
Navajit.
Navajit, yeah. And the Australian Indian Trauma System Collaboration aim to expand on that registry for to have a standardised approach that could be used anywhere in India. That work continues, and I would suggest that you reach out to either Navajit or to Amit Gupta, but many of you, I think, will be using that registry. In terms of post-hospital data collection, that is, it does sound difficult, but actually it's not that hard. It's all done by telephone using standard questionnaires and trained telephone interviewers. Most people now do, of course, have a telephone in India, in Australia, anywhere, right? So as long as you collect that information during their hospital stay, and you tell them you're going to ring them in 6 months' time, you're going to ring them in 12 months' time, you're going to ring them in 2 years. And if you've got somebody who actually does it using a standardized technique, you actually can get quite good follow-up. Our population is pretty static, doesn't move around too much, and we get very high rates of follow-up at 6 months. We get in the order of 90% follow-up at 12 months, and still 80% plus at 2 years. So it's a very powerful tool. Once you start to get thousands of patients with that data, it tells a very important story about the burden of injury and the importance of trauma for the Indian economy.
Yes. Thank you very much. Thank you, Dr. Rasid. And we all have learned a lot from you. Thanks a lot.
Thank you, Dr. Go.
We move forward in our session, and I invite Dr. Geeta Gag, my colleague at LTMJ Hospital many years ago, and now an additional professor at HBT Municipal Medical College and R.N. Cooper Hospital, Mumbai. She is also an ATLS faculty. Dr. Geeta will be talking to us on the pregnant trauma patient. Dr. Geeta, please.
Hello. Hello.
Yeah, Dr. Geeta, you're audible.
Yeah, there is some problem with my internet connection. Am I audible?
You are audible, but we can't see your screen.
I haven't shared. I haven't shared yet.
Can help her out? Can you?
Yeah, we can see you as well as we can hear you, Geeta. You can share your screen.
Can you see my screen?
Yes. Just go to slideshow.
Good evening, everyone. Thank you for inviting me for giving a talk on trauma in pregnant patient. Managing a pregnant trauma patient is a challenging situation in a trauma scenario, as there are multiple anatomical and physiological changes that occur in the mother, which makes it difficult to evaluate and manage the mother, as well as the interpretation of the diagnostic test becomes a difficult task. This influences the results of diagnostic tests, and it has an effect in the management of not only the mother but also the fetus. The priority is to patients, mother and fetus. There are certain anatomical and physiological changes that occur in pregnancy. There are changes, the uterus initially is an intrapelvic organ which becomes an abdominal organ by the 12th week of gestation, followed by, comes at umbilicus around 20 weeks, and it becomes, comes up to the xiphi sternum or at costal margin by 34 to 36 weeks. And then at 38 to 40 weeks, the head engages in the pelvis. So when these anatomical changes occur in the mother, there are certain implications of this. When you see this patient, you assess this patient. If you look at first trimester, uterus is an intrapelvic organ and it has thick musculature, because of which the fetus is well protected from direct injury. But in a serious impact of injury, there is always a chance of abortion, and that can lead to isoimmunization. Even blood as small as 0.01 ml can lead to isoimmunization in a Rh negative mother. Second trimester, again, uterus has become extrapelvic, but the fetus is at risk, but because of large amount of amniotic fluid, the fetus is still well protected, but there is always a chance of abruption because the muscle is, myometrium is elastic, but placenta is not so elastic, because of which there is shearing force leading to abruption, and that blood loss in the mother can lead to fetal distress because of vasoconstriction that occurs in the mother, and the placental supply becomes less and there can be fetal distress. This can also lead to amniotic fluid embolization and isoimmunization in all the trimesters. If you look at uterus in the third trimester, it is thin walled, so it is exposed to the direct blow which can occur in a trauma patient. The maternal abdominal viscera are displaced, but the fetus and the uterus are at risk of developing injury. The inferior vena cava is compressed in the third trimester. The risk in the third trimester is that there is a vertex lie, so if the pelvic fractures occur, there may be direct injury to the fetus. And also there is a high chance of maternal hemorrhage. And again, in fact, chances of abruption, amniotic fluid embolization, and isolation. These were the changes that occur in the mother during pregnancy, which makes the assessment difficult. But also there are certain physiological changes occurring in pregnancy, which make the evaluation and interpretation of the diagnostic tests and parameters of the patient difficult. If you look at certain changes, like there is increase in the blood volume, towards the term of pregnancy, the blood volume goes up to 1 to 1.5 liters. There is an increase in the blood volume up to 1 to 1.5 liters, leading to increased heart rate and increased cardiac output. Because of this, the interpretation of shock becomes difficult, because there has to be, before the mother presents with the signs of shock, there has to be, she can bear significant loss of blood. Mother may not present with the signs of shock, but there may be already fetal distress occurring, which if not interpreted can lead to loss of fetus. There is increase in the minute ventilation, which leads to decreased PCO2. Normally, in the non-pregnant state, the PCO2 is 35 to 40, which is normal. But in pregnancy, the PCO2 decreases to 30. So if a patient has a normal PCO2 in a trauma setting and the patient is pregnant, then there is a chance that we are going to miss impending respiratory failure. All these things have to be kept in mind while assessing the patient, because if there is a mistake in assessing these physiological changes, then one may lose the mother and the baby both. So coming to a pregnant patient's assessment, as always, ABCDE is a priority in all patients. One has to keep in mind that a pregnant trauma patient, how do I detect that a patient is pregnant? All the women of childbearing age who present to the emergency room should be considered pregnant unless proven otherwise. If the patient is in second or third trimester, we can see the enlarged uterus. Otherwise, based on the history, one can do pregnancy test and detect if the patient is pregnant or not. Coming to the primary survey, there are certain issues in ABCD which one has to bear in mind while assessing a pregnant patient. In airway, there is a very high chance of aspiration because gastric emptying time is increased, because of which the mother can aspirate. The contents may be present and aspiration is very likely. If ventilation is difficult because of shifting of the diaphragm, and because the diaphragm is shifted, there may be a problem while putting ICD. One has to bear in mind that ICD may have to kept in inserted in a higher space. As I said earlier, because of the increase in the blood volume, there is a failure to recognize the blood loss early. So if one is not aware that the signs of shock take more time to appear there before the blood loss, one has to monitor the fetus. If that is not recognized, then shock can be missed. And coming to eclampsia, because in head injury or in trauma patient, there is a possibility that patient may be having convulsions. Now, these convulsions could be due to head injury or it could be due to eclampsia, which one needs to differentiate from each other. In eclampsia, there will be proteinuria, there will be hyperreflexia and hypertension. Whereas in head injury, these findings may not be there. So one has to bear in mind whether patient is eclamptic or patient's seizures are due to neurosurgical problem. All these things make evaluation and management little challenging. Evaluation and management of a pregnant patient involves two lives, fetus and the mother. One has to follow the steps of primary survey and resuscitation of the mother, assessment of the fetus, secondary survey of the mother, definitive management of the mother and fetus. Because of the chances of isoimmunization, the mother may have to be given immunoglobulin, and early obstetric consultation are the key in the management and evaluation of a pregnant patient. Coming to evaluation and management of the mother, airway is same as non-pregnant patient. The priorities are same, A, B, C, D, E. In the breathing, as I said, chest tube placement has to be done carefully and it has to be placed in a higher intercostal space because one may land up damaging the diaphragm. Also, assessment of shock may be difficult because the patient is the blood loss, significant blood loss has to occur before the mother manifests with the signs of shock. So at that time, evaluation of the fetus will give us an idea. If there is fetal distress, that means there is impending shock. Mother is in shock, which is not getting detected. And as I said, eclampsia versus brain injury. Also, there is a very important point of PCO2. PCO2 should be maintained at 30 and it should not be normal for a non-pregnant patient, that is between 35 to 40. Coming to evaluation and management of the fetus, one has to resuscitate the mother because the causes of fetal death, majority of the times are maternal shock and maternal death. And the second cause of fetal death is abruption. So one has to monitor fetal heart sounds, monitor the mother. If the maternal tachycardia is more than 110, then that indicates that mother is in shock. And in fetal evaluate, there should be repeated assessment of fetal heart sounds. If the fetal heart sounds are less or more, that is less than 120 or more than 160 beats per minute, that indicates that there is fetal distress. Also, if the fetal heart, there is no beat to beat variation, or if there is repeated deceleration in the fetal heart sounds, that indicates that there is fetal distress and early obstetric consultation is to be taken. Also, if on examination one finds that there is vaginal bleeding, then there is a possibility of abruption or uterine rupture. Whenever there is uterine rupture, there is uterine tenderness, or if it is a contractile irritable uterus, then maybe patient is going in labor. And these findings have to be borne in mind while assessing the mother. So to summarize, there are anatomical and physiological changes of pregnancy, which pose a very challenging situation for the trauma surgeon to manage the patient. Patient's physiological parameters have to be assessed, keeping in mind all the changes that occur in pregnancy, and the interpretation, like patient's serum fibrinogen level are generally increased, but if fibrinogen levels are reduced, that means that is patient is going in DIC following injury, which has to be, if one is not aware that fibrinogen levels are increased, then this finding can be missed. So assessment and treatment priorities must be established for the mother and the fetus to manage a pregnant patient effectively. Thank you.
Thank you, Dr. Geeta. I have a question for you. Would you consider including obstetrician in your team as a part of protocol, whether there is fetal distress or not?
Yes, madam. If I said in between in my talk about if the patient seems to be in fetal distress, I will take an early obstetric consult. But if a patient is found to be pregnant, even if the patient is in first trimester of pregnancy, I would definitely involve an obstetrician as a part of my team management team.
Thank you very much. Thank you, Dr. Geeta. I think we have a question here. Is CT scan of brain absolutely contraindicated in a pregnant patient, even if absolutely needed?
No, it is not contraindicated, and with the abdominal shield, CT brain must be performed as and when indicated.
So would you say that the mother should be given a priority over the fetus?
Definitely, mother always gets priority over the fetus. Even in obstetric practice, when it is a question of life of mother and fetus, an adult gets priority, and the same holds true even in trauma scenario. The mother gets priority over fetus. Because if you save mother, there is a high chance you will save the fetus.
Thank you. Thank you, Dr. Geeta. Thanks a lot.
Thank you, ma'am.
We'll proceed to the next talk in this session. And this is the last presentation in this particular session too. And I invite Dr. Dinesh Bagaria, a young and enthusiastic trauma surgeon. And he'll be speaking on recent landmark trauma research. Dr. Bagaria, please.
Good evening, ma'am.
Good evening.
Am I audible?
Yes.
So I'm sharing my screen.
Yes, please.
I hope is it visible to all? Hello?
Yes, it is visible. Yes, we are
Okay,
able to.
thank you. So very good evening, respected seniors and dear friends and students. And thank you very much for the inviting and giving me honor of presenting in this national conference. And I will be speaking about the landmark research in the trauma. So what is the research? Research is seeing what everybody else has seen, but thinking what nobody else has thought. And if this thought, when associated with a properly collected scientific data, it becomes a landmark research. So I will be speaking about few individual modalities in the form of trauma system, trauma care system, resuscitation, investigation and management of a polytrauma patients, and what as a country India is contributing in this landmark research. War has caused a lot of harm to humanity, but it has also contributed in the immense development of the medicine. Hippocrates says, he who wishes to be a surgeon should go to the war, and war is the only proper school of the surgeon. And these wars, especially the Korean War, World War I and World War II, these led to the development of some fundamental principle in the medicine in form of emergency medical system and transport system. And these experience of these wars, American military physicians converted into the civil experience and ultimately lead to the development of civil trauma system. So the soldiers who were getting injured in these wars, they were being treated at general hospitals. And one vigilant surgeon, Von Wagner, he noticed that they are not being managed properly as per their trauma because of system failure. And he collected data of 3 years and presented in 1961, and he showed that at least 1 out of the 6 would have had an excellent survival chances if they had trauma diagnosis been made and adequately treatment instituted. In the same year, there were 2 and 3 more same reports who by and large showed that in-hospital management of trauma patients is not at par. And these lead to the unrest in the general masses, ultimately forced National Academy of Sciences to do a situational analysis. And this situational analysis presented in the form of a report. Name of report is Accidental Death and Disability, the Neglected Disease of Modern Society. This report was published in 1966 in USA. But if we go through this report, we will think that probably this report is all about India. And the major issues, the salient factors which they pointed out and required urgent attentions, they are all applicable to Indian scenario at present. The general public is by and large insensitive about the magnitude of the problem. Millions are lacking basic first aid, and there are very inadequate trained surgeons who are having who can management the polytrauma patients. The local political authority, they have always neglected their responsibility. The public health system is underutilized. There is no fundamental research program on the trauma care, and the emergency departments of the hospitals, they are overcrowded, and there is no systematic survey on the requirement of the resources. And these all situations we can assess that today they are applicable in the India too. So this report ultimately led to the development of what we call trauma center, the pinnacle of the trauma care. The very first civilian shock trauma unit, it was established in the Cook County Hospital in Chicago, 1966. And in the same year, in Baltimore, something happened which ultimately changed the course of the trauma management. And that was nothing but the establishment of the shock trauma center by none other than Professor Adam Cowley. The development of this trauma center, the history is very fascinating. In the 1960, Professor Cowley started a shock trauma unit with 2 beds, and he pursued his colleagues to send all the shock patients to this unit. And because these patients were sick, they used to come in the unit and used to die. And that's why Professor Cowley's colleagues used to call this unit a death lab. But ultimately, his effort got some colors, and few patients he was able to survive. And that's how he pursued the people to that there is shock which can be treated. And then he gave the concept of the golden hours. There is a golden hour between life and death. If you are critically injured, you have less than 60 minutes to survive. You might not die right then. It may be 3 days or 2 weeks later, but something has happened in your body that is irreparable. And this concept of golden hour is still applicable today in the development of EMS system. In 1968, by following the golden hour concept, he started first medevac transport in the EMS, and in 1973, he ultimately pursued the lawmakers to pass emergency medical services system. So the system, the development of trauma systems, they raise the eyebrow of the colleagues because they are very resource constraining. They suck very critical resource from other medical care. So there was a need to show that thus the system works, and the development of trauma system really helps. And that's then come the Don Trunke and John West, who in 1979 compare the two country, Orange country and San Francisco country. In the San Francisco, there was organized trauma system at that time, while in the Orange country, there was the contemporary system. They followed a timeline and analyzed 90 deaths in both the systems. In Orange country, they concluded that 11 out of the 30 days, out of 30 deaths, they were clearly preventable, while none of the death in the San Francisco was preventable. And 11 out of 30 deaths were judged as potentially preventable in Orange country, but in San Francisco, only 1 death seems to have a potentially preventable cause. And this report ultimately stamped that the trauma system works, and there is a need to development of the trauma system. In the following years, in 1986, again, there was a report which in San Diego country compared between pre-development quality of pre-development system and post-development system, and they showed there is reasonable decline in the preventable death as well as fatal outcome. Recently, in 2006, there was national evaluation in the USA by John Hopkins, and they also showed that the risk of death is significantly lower if the care is provided in a trauma center rather than a non-trauma center. So now there was a need to develop some tool through which we can compare the quality. And this tool was proposed by S.P. Baker in 1974 in the form of ISS. In the same year, there was development of a Glasgow Coma Scale by Tisdale and Janet. And these two scores are even today the very cornerstone of comparing outcome and measuring the quality. In 1981, there was development of PRISS, and based on that,
Dr.
major
Dinesh, your
trauma-
slides are not seen. Sorry to interrupt you. Your slides are not seen.
Okay, these are changing here. Let me. Is it visible now, sir?
No, it's not visible.
Shall I share it again?
Yeah, please share it again.
Just 1 minute. Is it visible, sir?
Yes, now it is visible. You can go to the slide from where this thing.
Sure. So the ISS was developed in 1974, and in the same year, the Glasgow Coma Scale was developed. And these two scores are still the cornerstone of the development of trauma system and compare the quality. TRIS was developed in 1981, and in 1990, there was a major trauma outcome study which established the norms of the standard of the care, which are still relevant and are being used to compare the quality. So these are the basic modalities where the research has led to the development in the form of therapy, monitoring, and medications, and few of them I will be discussing. The damage control surgery is the one name which thrill every trauma surgeon. And in 1981, Professor Mattox and Feliciano, they showed that in 11 patients who are hemorrhaging because of liver injury, the packing worked with them and they were able to survive. In the upcoming years, in 1983, the Stone described all the principle of the damage control surgery, which we today know, but it was the Frotondo and Schwab who still the showed and gave a fancy name of damage control to the approach and showed that in penetrating abdominal trauma, this approach works. And since then, we are using it in almost every trauma patient who are presenting to us with the shock. But nowadays, the trend is to quality improvement. And that's why in 2017, Brian Cotton shows that it's not like that each and every patient should undergo damage control laparotomy. There are certain principles which we should follow to decrease the use of damage control laparotomy as a quality improvement program. Fluid therapy has been a very paramount in the hemorrhagic shock treatment. And the very first description was in 1964 in animals. And since then, fluid resuscitation has been the cornerstone. It has become so popular that until unless your patient has developed pulmonary edema because of fluid development, he will be considered under resuscitated. And in 1991, it was again in the animal studies, it was shown that rapidly administered RL is not very beneficial, rather than it may harm also. And there come the principle of permissive hypotension, which was proposed not other than by Professor Mattox. And he showed that in penetrating torso injuries, if we delay the fluid resuscitation till the time hemorrhage is controlled, the outcome is better. And in subsequent year in 2011, he showed that in a randomized control trial that hypotensive resuscitation lead to decreased transfusion requirement and decrease the post-operative coagulopathy. But how we should measure the resuscitation? Then come the best deficit and the role of lactate to measure the adequacy of the resuscitation. Blood product have been probably the second best fluid which trauma surgeon likes. And Brian Cotton again came into the picture, and he gave the concept of damage control hematology, that if the predetermined protocol of ratio blood product is being transfused, the outcome is better. But what should be the ratio? The prompt study shows that if the ratio is higher, it is 1:1 or more, then it is always better compared to the ratio of 1:2 or 1:3 or 4. And then come the proper study in 2016, which settled this debate and ultimately showed that 1:1:1 ratio is the winner, and we should follow that. And the ultimate motto behind using this ratio is to achieve the whole blood mimic the whole blood transfusion. And the military experience from Iraq and Afghanistan of US physicians showed that the fresh whole blood is also a better modality compared to the component transfusion, and the same was used in the civilian trauma in 2016. Calcium has been a very neglected ion till now, but recently it has gained momentum, and now the calcium is considered a very important as acidosis, hypothermia, and coagulation. And now the concept is of not the triad of death, but it is the quadrangle or diamond of the death. The coagulopathy, all these ultimately lead to the coagulopathy. The very first concept of the coagulopathy was proposed none other than by Karim Brohi from London, and since then he has been very vital, very active on working on the coagulopathy, and he has proposed and showed multiple studies on various aspects of the coagulopathy. The measurement of the coagulopathy till traditionally was used by test which we use in the labs, but in 2007 ROTEM came into the picture, and they showed that it is useful to use ROTEM in the trauma patients, and we can better assess the coagulopathy patients, and we can manage patients better using ROTEM. But again, the iTactic trial, again by not other than Karim Brohi, showed that either we are using conventional coagulation test or viscoelastic assay in form of ROTEM, it is not going to make major difference in generalized patient, although he showed that the TBI patient might benefit from them. Since then, there has been a debate of using conventional test or the viscoelastic test. So there comes the picture of the factors, and based on these tag finding, we can use individual factors to be used for the management of the trauma patients. Ken Beaufort shows that the recombinant factor 7 is a good adjunctive for the resuscitation and led the favorable outcome. Trenexa has been used previously in other hemorrhagic emergencies, but it was the CRASH 2 trial in 2010 which established its role, dose, and timing in the trauma patients. And in 2012, the CRASH 3 trial showed that the Trenexa also have role in management of brain injuries. And all these modalities in the form of permissive hypotension, damage control surgery, use of Trenexa, blood products, ultimately came together and developed a principle called damage control resuscitation. And again, the Brian Cottam came into the picture and showed that this resuscitation principle is very important. And he shows that if in the patient we follow the principle of damage control resuscitation, 30-day survival is much better compared to the normal patients. Riboa is being used nowadays as an adjunct of the resuscitation. In 2010, it first came into the picture in the pelvic fractures, and since then there has been multiple reports in favor or against the use of Riboa. Unfortunately, this modality is not available in India, and AIMS Trauma Center is working to get this modality in India. So recently a conference, a live workshop was organized by Trauma Center in collaboration with the Örebro University, Sweden, on the Riboa. Penetrating hair injuries are very fascinating, and before 1977, the exploration of every penetrating injury was the rule rather than exception. So in 1977, the peritoneal lavage and local wound exploration showed that we can use this modality rather than exploring each and every individual of penetrating injury. And since then, the trend has been to use the least invasive modality. 2003, the diagnostic laparoscopy came in the picture, and this very first RCT, although showed that the diagnostic laparoscopy is not useful, still it opened the door of laparoscopy in the trauma, and there has been since then multiple reports of use of diagnostic laparoscopy in the penetrating injury patients. Then in 2004, the Thomas Scalia, again from the Shock Trauma Center, used the CT scan, and they showed that a CT scan is equally useful and can be used in penetrating trauma patients to diagnose their injuries. And since then, the debate of using CT scan versus the diagnostic laparoscopy is going on till the time any good RCT comes. The 1993, this report is one which handed the ultrasound probe in the hand of the surgeon, and surgeon started using it at least in acute care, and showed that the use of ultrasound in the hand of surgeon is equally good compared to the radiologist. And since then, FAST has been a very important modality in the trauma care. Recent development, recent interest has been in the surgical fixation of the rib fractures. The very first refixation was proposed in 2002 by Tanaka, and then in 2013 by Fitzgerald. And since then, multiple reports have came describing the refixation role in a flail chest, in non-flail chest, in ventilator patients, and still the debate is going on. And nowadays, every day we are reading a new report on the SSR. This is the very first report.
Dr. Dinesh, actually, we are a little bit running out of time.
Sure.
Can you just...
So this is the 1968 report, which by Upadhyay, which established the non-operative management in the solid organ injuries, especially the splenic injury. And since then, solid organ injuries are being managed non-operatively. This was a very landmark report by Debicki in 1946 and described the principle of management of arterial injuries. And these principles are still being followed in letter and spirit. As far as the India is concerned, if you see the report generated by India on the trauma and injuries, it is the last 10 years where the reports are majorly being produced. The descriptive studies are primarily by the public health experts or some orthopedician, but trauma surgeon unfortunately are not majorly involved in these injuries. There has been few reports to assess the capacity assessment and the impact of a training program in the form of ATLS on the trauma care, and some individual center studies or a individual project studies to assess the outcome in the inpatient management. AITSC again has been a very paramount in international collaboration, because it gave us the idea of trauma registry as well as the quality improvement in the trauma. The one article is the Ganga Hospital score, which is probably a score which gave us India a international picture, and this Ganga score is being used in open tibia fracture very frequently. This is the another recently published article, which is RCT, and it explored the role of ERAS principle in the trauma patients. This is the one collaboration among India which almost involved every trauma surgeon in the country, and ultimately lead to the this consensus guideline under the aegis of STEC society. So, ladies and gentlemen, I would like to conclude my talk with this with these three quotations: that history is not a burden on the memory, but an illumination of the soul. And if we have emotion about the management of these trauma patients, this illumination will definitely enlighten our soul. Without data, we are just another person with opinion, and that is the problem probably in India, that we have an opinion, we have strong opinion because we are managing patient day and night, but because of not able to collect good and timely data, we are not able to generate the research. And collaboration is the new non-technical surgical skill, and each and everyone we should learn this skill and we should collaborate further. Thank you very much for this opportunity, and greetings from the Division of Trauma Surgery and Critical Care to all the attendees of the Traumasicon 2021. Thank you very much.
Thank you, Dr. Dinesh. And I hope that your sharing of the research from all over the world provides some stimulus to those who are working in this field of trauma, as we have no dearth of number of cases with trauma, but what we lack is research attitude and publications. So I hope we do see more and more publications and more research coming from our own country. Thank you very much.
Thank you.
Thank you,
Thank you
Dinesh. And with this, we end this session 2 of today's program. And I would like to thank the organizers of Traumasicon for inviting me to be the chairperson. Thank you very much.
Thank you very much, madam, for taking out your precious time and chairing this session. We had 3 stalwarts speaking in this session, and you have conducted the session very well. Thank you very much, madam.
Thank you.
Thank you.
Thank you.
We start with the next session, and may I call upon Dr. Ellen Mohan, who is chairing the session, which is a symposium on damage control surgery. Veena, can you play the introductory slide? Can you show the introductory slide of Dr. Ellen Mohan? Professor Ellen Mohan is presently professor at Videhi Institute of Medical Sciences and Research Center, Bangalore. He was previously professor and head Department of Surgery at St. John's Medical College, Bangalore. He has been an ATLS faculty, as well as he has various international and national publications. With the 34 years of teaching and clinical experience, I'm sure he's going to conduct the symposium in a very good manner. May I now invite Professor Ellen Mohan, sir, to take the proceedings from here. Thank you. Professor Mohan, sir. Professor Mohan, sir. I think there is some connectivity problem. Can I get Dr. Professor Mohan? Okay, so I think there are some technical issues. We will start with the first presentation, which is going to be done by Dr. Mohit Joshi, and he's going to talk about damage controls resuscitation. He's basically primarily a trauma surgeon who has been trained in AIMS and presently working in JPN Apex Trauma Center. I would like to invite Dr. Mohit Joshi, a good friend and a trauma and ATLS faculty, to give his talk.
Thank you
Dr.
so much.
Mohit, are you there?
This.
Yeah.
Yes, I am there, sir. Thank you so much for this brief introduction. And I would like to thank the organizers for inviting me to talk on this topic, which is damage control resuscitation. I'm sharing my slides and just give me a go if they are visible.
Yes, they are seen. Yes, we are seeing the slides.
Right. So we will discuss about damage control resuscitation in this session. And what I plan to do in next 15 minutes or so, I'll just tell you what exactly is damage control resuscitation. We have heard so many terminologies like damage control approach, damage control resuscitation, damage control surgery, and damage control laparotomy. So I'll try to clarify as to are these terms they are same or they are different, although they are used interchangeably in the literature. I'll give you a short historical perspective on resuscitation. We'll deliberate on components of damage control resuscitation then. And of course, I'll give you some practical tips for practicing damage control resuscitation coupled with what we practice here. So what exactly is damage control resuscitation? It is defined as a systematic approach to resuscitation in major trauma hemorrhage, which incorporates some strategies which improve the outcome. What these strategies are, we're going to discuss them today. So there is some confusion between these terminologies, which are often kind of mixed. So if we see damage control approach, it's a wider term that involves damage control resuscitation and damage control surgery. But as we know that controlling hemorrhage becomes part of resuscitation, so ultimately this damage control surgery is part of damage control resuscitation. Hope this will clear out the difference between these terminologies. Let's see this way also. So when you talk about damage control resuscitation, this resuscitation starts from ED, OR, and continues to ICU. Now in ED, it contains something called as balanced resuscitation, correction of coagulopathy, initiation of massive hemorrhage protocol, and the use of antifibrinolytics. Now this DCR or damage control resuscitation, it continues in operating room for controlling the hemorrhage. And then this damage control surgery may be somewhat like damage control laparotomy, damage control thoracotomy, damage control vascular surgery, and so on. This resuscitation then continues when the patient is shifted to ICU, and then everything is done to control the triad of death, that coagulopathy, hypothermia, and acidosis. So in these three stations, these becomes the component of something called as damage control resuscitation. Let's see it from the historical perspective. So way back in early part of 20th century, there was hardly any concept of resuscitation. And of course, then it was marred by poor outcome, and it was considered that this poor outcome is because of wound toxin or some evil humus because of injury. In next 20, 25 years or so, the shock became known as an entity, and then resuscitation with whole blood and colloided started. Although it was understood poorly, but then this was coupled with decreased early mortality, but at the same time was associated with delayed organ failure and death. As the time progressed, so the physiology of shock, it kept on evolving over time. And the resuscitation with large volume of crystalloid and whole blood, it continued. Then somewhere in 70s and 80s came the concept of blood bank in component separation. Mind you, this was just out because of cost constraints and resource allocation. So because of this component separation, in resuscitation, the whole blood was replaced by packed red blood cell. But then the large volume resuscitation still continued. And other components of blood, they were not used for resuscitation. This is so very interesting. Now, what happened recently? So as we discussed earlier also, that the concept of damage control surgery came somewhere in the later part of 20th century. But still, there was no concept of damage control resuscitation. It came into picture only after 2005. So it was almost 25 years after the concept of DCS that DCR started. And we have seen this evolving over time. So when we started training in ATLS and teaching ATLS, so this was the 8th edition, which came somewhere in 2008. And if you see this manual, it was written that the initial fluid bolus should be 1 to 2 liters. Although it was mentioned as 1 to 2 liters, but traditional teaching was to give at least, and I remember it very distinctly, give at least 2 liters of crystalloid to any patient who presents in shock. And there was no concept of balanced resuscitation way back then. Then came the next edition, which came somewhere in 2012. And here, again, the stress was on 1 to 2 liters of fluid for adults in shock, but then we progressively migrated from 2 to 1 liter. And in this manual, for the first time, the concept of balanced resuscitation was introduced. With the recent edition, the 10th edition of ATLS, which came back in 2018, now you see that the volume has been reduced from 1 to 2 liters to 1 liter. And for the first time, this manual, it emphasizes on early use of blood products. It mentions the coagulopathy in trauma, the use of massive hemorrhage protocol, and the use of tranexamic acid. So this is how the resuscitation practices, it has evolved over time. And we have seen all these things in front of us in last 15 years or so. But what made people change this practice? Of course, the physiology of shock was understood better with time. And with this came a very strong notion that achieving normal blood pressure before definitive hemorrhage control is counterproductive. It increases chances of bleeding, it exacerbates the triad of death, and it activates the inflammatory cascade by way of protein C activation. So this was known recently. It was also understood that the coagulopathy sets in early, and the use of blood products early in resuscitation, it either prevents or corrects the coagulopathy of trauma. So these understandings, they change the practice of resuscitation over time. So with this background, let's go back to the components of damage control resuscitation. So just to enumerate them again, they were balanced resuscitation. Now this term is also used interchangeably, and it's like synonymous with something called as hypotensive resuscitation, permissive hypotension, or minimal normotension. Now, I was also surprised that why we have so many terms for one particular thing, but here you see that when we talk about hypotensive resuscitation or permissive hypotension, somehow these two terms, they connotes that probably hypotension is an essential part of this resuscitation, which is not. It just underlies the importance that the initial fluid resuscitation should not be over-aggressive. We'll discuss about this a little later. Then the other component was early correction of coagulopathy. This is so very important. And by way of initiating massive hemorrhage protocol wherever it is required, and hemostatic resuscitation, that is resuscitation by using the blood products early in the ratio of 1:1:1, is now the standard to correct the coagulopathy. And then one of the component was the selective use of antifibrinolytics. As we discussed earlier, that surgery is not separate from it, because hemorrhage control becomes part of resuscitation. So damage control surgery will be part of this. I'll not be explaining this because in the subsequent session, Dr. Subodh will take you through this damage control surgery. Let's discuss these components one by one. What about balance resuscitation? So what this balance is all about? This balance is about the organ perfusion and the risk of rebleeding by accepting a physiological blood pressure which may be lower than the normal blood pressures values. So this is a balance between organ perfusion and avoidance of rebleeding by accepting a blood pressure which may be lower than normal. Again, we have to use the word hypotensive resuscitation or permissive hypotension with caution, because somehow they suggest that hypotension is an essential part of this management, which is not. Although it sounds very simple, but it's very challenging to practice. It's been there for almost like kind of 15, 16 years now, but there is no standard algorithmic approach, and no wonder, because the practice of balance resuscitation and the outcome of patients by using this mechanism, it is affected by the age of the patient, the mechanism of injury, whether the patient has blunt or penetrating injuries, whether the patient has associated head injury, and if there are any cardiac comorbidities the patient is having. So it should be considered carefully on case-to-case basis. There cannot be one formula which will fit all the patients. So various approaches they have been proposed to practice balance resuscitation, but over the time there has not been any consensus on numerical cutoff values of blood pressure, because it may be different from one patient to the other. Nonetheless, like it is suggested that the resuscitation, fluid resuscitation rather, it should be in the volume of 60 to 80 ml per kg per hour of the patient to maintain the blood pressure just sufficient enough to maintain the organ perfusion. So in case of blunt injuries, it should be somewhere around 80 to 90. In case of penetrating, it can go down up to 60 to 70. Although, a word of caution here, these are just guidelines, or these figures are there just for guidance. They are not sacrosanct. It is also suggested that the patient should be given 100 to 200 ml of fluid boluses and see the physiological response. This approach is definitely contraindicated in case of traumatic brain injury, because we know that if the blood pressure, systolic blood pressure in patients with severe brain injury, it goes below 90, it increases the chances of secondary brain injury, and it is associated with poor outcome. The second component was coagulopathy. And with the understanding of coagulopathy of trauma, it is now known that the coagulopathy is not dilutional alone. So it's not that the blood has been lost and we are replacing it with fluid or blood products which are lacking in the endogenous products. This coagulopathy of trauma is inherent, it's endogenous by way of protein C activation, which occurs in case of the patients with massive injuries. It has been seen that it sets in early, like something of like systemic inflammatory response syndrome, and without resuscitation. So it's not only dilutional, it's endogenous as well. How it can be addressed? So the patient should be asked about the history of coagulation disorders. As the patient is taking the anticoagulant medications, the baseline values of PT, APTT, INR platelet count will definitely make us more wiser. And if the facility of thromboelastography or rotational thromboelastometry is available, it should be used to assess the level of coagulation in the patient to guide the therapy further. Now, by using the blood products early, limiting the crystalloid infusion, by using a high plasma to PRBC ratio, and infusing platelets early so that we have a ratio of 1:1:1 of RBC, platelets and plasma, probably this coagulopathy of trauma, it can be either reversed or it can be limited. At times we'll have some patients in which we'll require a large volume of transfusion. Now these patients which require massive transfusion, in such patients, one must have a protocol of massive hemorrhage in place. There must be a good coordination between ED and blood bank. And if this protocol is in place, it avoids confusion and delay in getting the blood products, and it ensures that the patient has that hemostatic resuscitation in the ratio of 1:1:1. Regarding use of antifibrillatics, like Dr. Dinesh also told about this trial, the CRASH-2 trial, the greatest strength of this trial is the sample size. So it included more than 20,000 patients. And it showed definitely that if this drug, the tranexamic acid, is administered within 3 hours of injury, it decreases the all-cause mortality by 1.5% and death due to rebleeding from about like 0.8%. But the people, they have been very critical about this trial, and the use of tranexamic acid either has not been universal and it has not been uniform also. What we practice regarding balanced resuscitation and hemostatic resuscitation is that we initially give 1 liter of warm crystalloid to patients who come in shock. We liberally use blood products early in resuscitation, definitely with an understanding that the achievement of normal or supernormal blood pressure is not the idea before definitive control of hemorrhage. We tailor approach on case-to-case basis, depending on how the patient responds, and we guide the resuscitation by patient's physiological responses and the results of thromboelastography. We use tranexamic acid selectively in patients who receive massive hemorrhage protocol. This is our TEG machine, and this is one of the test result. We have a massive hemorrhage protocol in place, and we have given all liberty to our senior resident who is working in our AD to activate the protocol. So in case you find any patient who is non-responder or transient responder, he can activate the massive hemorrhage protocol. This is a very good understanding between the blood bank and ED that as soon as the protocol is activated, the blood is released. So blood request forms, they are not required. They may be accepted later. As soon as it is activated, the blood products, they are released in 4 batches. Initially, O positive or negative blood is given depending on the gender of the patient, and subsequently group specific and uncross matched blood is given over the next 45 minutes. Platelets, they are made available early so as to maintain the ratio of 1:1:1. After 45 minutes, this protocol, it terminates automatically, and if the patient requires any more blood, then it is released on request, and at that time this blood is fully cross-matched. So we'll take the question at the end of the session, and I will be very happy taking the questions. I'll just summarize what we discussed in last 15 minutes or so, that the damage control approach, it includes both damage control resuscitation and damage control surgery. In fact, damage control surgery is part of damage control resuscitation. This resuscitation practice is a systematic approach of resuscitation, which should be used in patients having massive hemorrhage and is shown to improve the outcome. This involves something called as balanced resuscitation. We now know what it is. Correction of coagulopathy of trauma, initiation of massive hemorrhage protocol wherever it is required, and selective use of tranexamic acid. You must understand this balanced resuscitation is the balance between organ perfusion and risk of rebleeding. Hypotension term, although it is associated with it is not the aim. The aim is controlled resuscitation. We must use blood products early that blunts the coagulopathy of trauma. Massive hemorrhage protocol, it ensures hemostatic resuscitation, and tranexamic acid can be used selectively in some patients as it has been shown to be beneficial. Thank you so much.
Mohan sir, you're not audible, sir. Can you are unmuted, but you're not audible, sir.
Girish sir, you can just please take down the question from the chat box.
Yes, actually the questions are going to be asked at the end of the speaker. Thank you, Dr. Mohit, for an excellent talk. Mohan sir, your audio is not working. Can you check it on that? Thank you, Dr. Mohit. There is a question answer session at the end of when all the 3 speakers have spoken. Thank you very much. I will again invite you for all the questions and
Sure. I'm there. Thank you, sir.
Thank you. Thank you. Can I invite next speaker, Professor Subodh Kumar sir? Veena, can you show the introductory slide, please? Dr. Subodh Kumar sir is Professor at JP and Apex Trauma Center, AIMS, New Delhi. He's an international fellow of Association of Surgeons of Trauma. He is an ATLS faculty and director, vice president of ISTAC, and he has more than 150 publications to his name. He has taught many of us the basics of ATLS. So I invite Professor Subodh Kumar, sir, please.
Thank you, Dr. Girish. Thank you very much. And at the outset, I would like to thank the organizers for giving me this opportunity to address this August gathering, though virtually, but I think in this pandemic, this is the way, new normal. So I think without wasting much time, actually, Mohit has done my job very simple, and he beautifully described the damage control resuscitation. And damage control laparotomy, he rightly said that it is actually a continuation of care of a patient who is bleeding, and you have to start managing the patient in the ER itself. And believe me, that if you manage these patients well in the ER, the outcome will be very fruitful. So greetings from my institute. So I start with the case scenario. He is a 30-year-old biker hit by a truck, brought to the ED within 90 minutes of injury. The primary survey airway was patent. His respiratory was 30, oxygen saturation 97%, but his heart rate was 140 per minute. BP was 87 by 57, cold clammy extremities, and I'm sure all of you will agree that he was in shock. And in trauma, we say that if patient is shocked, it is because of, until proved otherwise, it's because of hemorrhage. So his fast was positive, and as a part of the initial management, he was given 1 liter of warm ringer lactate, but he did not respond, so he was labeled as non-responder, and he was immediately shifted to the OR. No further imaging like CT scan at this stage. And intraoperatively, there was a massive hemoperitoneum. There was a bucket handle injury with devascularized small bowel. Hemostasis achieved. Stapled resection of the bowel was done. No attempt was made to anastomose the bowel. Temporary abdominal closure was done using a mesh laparostomy. He was shifted to the ICU, and the total OR time was 15 minutes. And although it looks very tempting in this picture that we can do a quick anastomosis of the bowel, but we restrained ourselves. The resuscitation continued in the ICU. He was managed in the ICU. All the resuscitative measures were taken. His heart rate improved to 90 per minute, blood pressure 110 by 70. He became normothermic. He was again shifted to the OR. I will request all of
Sir, you are muted.
Subodh Kumar, sir, unfortunately, you have been muted, sir. Sir, can you unmute yourself, please?
Yeah, I have unmuted, but please mute everybody
Thank
else.
you. Yeah. Yes, sir.
So the patient was again shifted to the OR after 36 hours for second surgery, and this time a side-to-side ileoileal anastomosis was done. Abdomen was closed in layers, and we could discharge this patient on post-injury day. I wonder if we would have attempted a definitive repair during the first surgery, we would have lost this patient. And I'm sure all of you will agree with me. So what is the, I can't move this slide. I can't move these slides.
So can you stop sharing and again start sharing? Sometimes this happens, sir.
Okay, I'll do that. I think it's still, there are disturbances. Somebody is speaking. You have to mute them.
Can the event management team take action against? Please mute.
Lot of disturbances. So the concept of the damage control surgery is keep the patient alive at all costs. Treat the first, what kills first, and treat the physiology of the patient. We all have seen this trauma triad of death, which includes the acidosis, coagulopathy, and hypothermia, and it leads to, and if all three are present, I think it's very difficult to save these patients. But this process can be reversed. This process can be reversed right in the ED itself by doing a protocolized assessment and management of these patients, which actually Mohit beautifully described during the primary survey. And if you find, as in our case, he is a non-responder, shift him to the OR for damage control laparotomy without doing any detailed secondary survey and without any further imaging. You don't need any imaging to establish. The only imaging you need is the FAST in the ED. And if FAST is positive in the abdomen, shift the patient to the OR to stop the bleeding. Because stoppage of bleeding, this is a surgical control of hemorrhage, is the single most important factor which can reverse this process of coagulopathy, acidosis. It will improve the body temperature of the patient, and ultimately it will improve the shock of the patient. And what should be done in the ER in a non-responder, in the OR in a non-responder patient? The concept of abbreviated laparotomy, which actually Dr. Stone gave this concept of abbreviated laparotomy to manage the coagulopathy in these patients by technique of initial abortion of the laparotomy, establishment of intra-abdominal packing, and completion of the surgical procedure once the coagulation has returned to an acceptable level. And he proved that it could be a life-saving approach. And actually, his concept of abbreviated laparotomy was used by Rotundo et al. And they coined this term of damage control. And actually, the damage control concept came way back in the Navy, when they start and they keep the ship afloat at any cost. And he used the same concept and named it damage control approach. During the surgery, which includes 3 stages, one is the initial control of hemorrhage and limit the contamination, intra-abdominal packing, temporary abdominal closure, restoration of the normal physiology in the ICU, and bring back the patient to the OR after 48 to 72 hours for a definitive laparotomy with reconstruction. What damage control is not about? It is neither a bailout procedure nor an abandonment of proper surgical technique. It is a deliberate and calculated surgical approach requiring mature surgical judgment. And definitely it is not a failure, it is a continuity of care. It's a mature surgical judgment. So as you all know, the damage control surgery, initially it was proposed 3 stages, not more than 45 minutes in the OR, continue resuscitation in the ICU, and definitive surgery after 48 to 72 hours for more definitive surgeries. But then 2 stages were added to this concept of damage control surgery, and then we call it a damage control resuscitation. One is the damage control 0 phase in the ER before shifting the patient to the OR. And one stage is more reconstructive procedure at a later date, maybe after a week or month or years. So damage control surgery resuscitation is the mother. Then damage control surgery is a part of the damage control resuscitation. And anything can be damage control surgery, which includes laparotomy, thoracotomy, or vascular surgery. Who are the patients who actually qualified to be taken up for damage control laparotomy? If patient is continued to be in shock after initial resuscitation in the ER, hypothermic, acidotic, shock index more than 0.9, coagulopathy, massive, he requires massive blood transfusion. If you are during surgery, if you are contemplating the operative time will be more than 90 minutes, or he has a high ISS, the injuries are more, which will take a lot of time to correct them, and patient in shock, like he has a major trauma, major torso trauma, major vascular injuries. So these are the patients who are a candidate for damage control laparoscopy. So I will not go into the detail of the balance decision. Dr. Mohit has beautifully done that. We have to use early blood and warm fluids, warm the patient, hypotensive vegetation in the AR, and shift the patient early for surgical hemorrhage control. Before shifting the patient to OR, there's one thing that Mohit also showed, the RIBOA, and though I think Dinesh showed the concept of the RIBOA. So this RIBOA is a resuscitative endoluminal balloon occlusion of aorta. It's an ED procedure. Unfortunately, we don't have this facility in India. This is the catheter which is being used. But we are making some efforts, and my colleague, Dr. Mohit, he did a study and he used this catheter. This is the orthoplastic catheter, used for balloon catheter for orthoplasty before placement of a stent in the aorta. And he used this stent, and I'm really thankful to Mohit for sharing this with me. And what he did, he opacified the aorta in a cadaver from above to visualize that aorta is patent. And then what he did, he introduced the catheter through one of the femoral arteries up to 27 centimeters so that he can reach the zone 3. And this is the zone 3 of the aorta, we all know, in the infrarenal portion. Because this procedure is most useful in patients with the pelvic trauma. And then he inflated the balloon with a contrast to see that the balloon inflated in the aorta. And then what he did, that then again he deflated the balloon and inflated with saline. And he introduced the contrast from above, just to show that contrast is not going down as you see in this picture. So contrast is, you can see this, the contrast is up to this upper level of this balloon. So it works. It works in a cadaveric model, and I am sure that we will plan some study to use this catheter in place of the commercially available RIBOA catheter. So if you have a RIBOA catheter facility, you can use that before shifting to the patient to the OR. Now, the next stage is the shift in the OR. Before shifting to the OR, instruct the OR manager or OR nurse, stop the air conditioning, start the warmers, start the timer. Time is of essence. Prepare the trolley. We should have a good self-retaining retractors, a laparotomy, thoracotomy, vascular sets, and shift the patient under care. He should be accompanied by a doctor to the OR. And if we have the facility of hybrid OR, that is the best thing we can have. The goal of damage control laparotomy is the hemorrhage control, limiting the peritoneal contamination, and temporary abdominal closure. This is the position of the patient. Wide operative field. Sterility is a luxury in a damage control laparotomy. You have to decide within 5 minutes. Access, temporary control of bleeding, exploration, and decide whether you are going for a damage control or a definitive goal. It's a great equalizer of trauma surgery, damage control. So what we traditionally do, initially suck and pack all the 4 quadrants with big towel, and then remove the packs one by one. And if it is a liver bleeding, then nothing more than perihepatic plaquing. It has been proved beyond doubt the perihepatic packing is the answer for liver injury. Nothing short of splenectomy for spleen. There is no role of splenography or the reimplantation of the splenic segment. Nothing short of splenectomy if in damage control laparotomy. Nothing short of nephrectomy if renal injury is the cause of shock. For pelvic fracture, what we do, although some of you may find it controversial, that we do bilateral intra-iliac ligation with periperitoneal packing in a non-responder patient who is having a pelvic fracture. And I'll share you a small video that what we do a laparotomy, and then we identify the common iliac artery and the bifurcation of the common iliac artery. This is the external iliac artery. This is the internal iliac artery, which was clipped in continuity. You can use the suture. There is no need to cut the internal iliac artery. It will reduce the bleeding definitely, because although we know that 90% of the patient it's a venous bleeding, but in 10% or 20% of the patient it could be arterial bleeding. But definitely the ligation of the internal iliac artery will reduce the pressure in the pelvis. And we have actually sent our experience for.
You have to swipe your hands in the preperitoneal.
And then after doing the bilateral internal iliac artery ligation, we do the preperitoneal pelvic packing. We can, ideally we should use the packs, but we can use the, initially we can use the ribbon gauze, and then we can use the pack, but it's a space of ridges. It's a pre-vesical or retropubic space. After doing the packing, if need be, we can apply a external fixator and then shift the patient to ICU for continued resuscitation. Then the next step is to limit the contamination. All the bowel injuries should be addressed. You can use the skin staplers, stapling devices, bowel clamps, umbilical tapes. You can use just 2 or 3 or silk sutures for quick repair of non-circumferential hole, and always use the linear drainage. So what you have done, this is okay, hemorrhage control, limit the contamination is okay. But what is not okay in damage control laboratory? This is not okay. This is not acceptable. Definitely repair is not acceptable. And then followed by temporary abdominal closure using the towel clips, elastic bag, Euro bag, steri drapes, mesh laparostomy. If you are rich, you have the facility for this vacuum assist device, you can use that. Then shift the patient to the OR for continued resuscitation. This is the place where the outcome is determined. It is not your routine post-op patient. It requires a team effort. You have to, patient still maybe in coagulopathy and hypothermic or acidotic. So what you have to do, continue the, give him warm bloods, prevent hypothermia, continue with the balanced resuscitation. And the resuscitation should be guided by the viscoelastic assay resuscitation. The asystosis should be guided by these frequent ABGs. And once your patient has been stabilized, bring him back to the OR. This is a more controlled environment, and then you can do whatever surgery you want to do because your patient has been stabilized. He may require multiple trips to the OR. So I would like to conclude by saying that update your team, get help. Whenever you see a patient who is in shock and who is a non-responder, get blood, adequate blood, improve the exposure, stop the bleeding at the first place, and stop that temptation that I am very quick in handling these patients. I can do the anastomosis very quickly within no time. We have to stop that temptation because we all know that live problem is better than a dead solution. We want to have a live patient with some problem, but we don't want a dead patient. This is our experience of damage control surgery. We have published our experience of 6 years. So the future, I wish that we have an ideal fluid for resuscitation. We have an ideal transfusion ratio. Yes, there is a consensus about the 1:1:1, but still, I feel that ideal has to come. And if I wish that if we have improved abdominal closure techniques available. So the modern operation is safe for patient. The modern surgeon must make patients safe for modern operations. So with this, I end my talk. Thank you very much for patient listening, and I'll be happy to take the answers, the questions at the end of session.
Mohan sir, please unmute yourself. Mohan sir, we can see you, but you have not unmuted.
Now, am I audible?
Yes, you are audible, sir. Yes.
Yeah. Just wanted to thank Dr. Subodh. He's done a wonderful job as usual, with his vast experience of damage control laboratory. I think we're taking the questions at the end of the next lecture. So I request the thank you slide to come up, please.
Veena, at the event management, can you?
The next speaker is Dr. Raj Shekhar from Salem. He is working in Manipal Hospital, Salem, and he is also the chairman of the Tamil Nadu chapter of ASI. He is an MRCS examiner and an RCS from the Royal College of Surgeons of Edinburgh. He is speaking on sequelae of damage control surgery. Over to you, Dr. Raj Shekhar.
Thank you, sir. Greetings from Tamil Nadu ASI. Yeah. Being the last player of the first innings, I need not worry because the previous batsmen have played like English team and we have enough scores. I need not worry about the scores. Anyway, as we all seen the impact of the damage control surgery, obviously the morbidity mortality is going to be significantly high. And this is a collective review which shows that the morbidity as well as the mortality, which ranges from 12 to 67%, and with the morbidity like wound complications, intra-abdominal abscess, dehiscence, enterocutaneous fistula, abdominal compartment syndrome. So the immediate postoperative period in the ICU or after definitive surgery, one is a continued bleeding, maybe because of the coagulopathy, and the abdominal compartment syndrome and ischemic tissue, which can lead on to metabolic derangements and gastrointestinal soil or anastomotic leak or missed injury. The postoperative bleeding can either be a discrete bleeding or it could be a diffuse bleeding. Discrete bleeding due to vascular injury while ligating the bleeder, or it could be a suture displacement or inadequate vascular occlusion, or sometimes a missed injury from the solid organs or a vascular injury. The difficult part is managing the diffuse bleeding, which is a real challenge because of the ongoing coagulopathy, and where your energy source may not control the bleeding. It's a diffuse bleeding. Only option you may have is an abdominal packing and shift the patient to ICU and resuscitate and bring back. And whenever you have to intervene to control the surgical bleeding, do not disturb the unnecessary hematomas, particularly around the liver or retroperitoneal, when it's not disturbing, unless it's going to be a pulsatile hematoma where there is an underlying vascular injury. Otherwise, we may have some problems. The embolization may have an additional role, particularly in liver injuries where you pack and still the patient is bleeding. Adjuvant use of angioembolization may improve survival in patients with a liver injury. Similarly, it was very well told about the pelvic injuries, where if facilities are available, hybrid or ligation of the internal iliac vessels can control the bleeding. If facilities are not there, best is to pack and then subject the patient in the postoperative period for angioembolization. The abdominal compartment syndrome, the incidence of intra-abdominal hypertension is ranged from 2 to 50%, and abdominal compartment syndrome 0.6 to 36%. So usually this is measured with a transvesical catheter, and the definition as per the World Society of Abdominal Compartment Syndrome is defined, intra-abdominal hypertension is defined as a sustained or repeated pathological elevation of IAP more than 12 millimeters of mercury. When there is a sustained increase in IAP for more than 20 millimeters of mercury, it is a abdominal compartment syndrome, which may be a primary, secondary, or recurrent. Primary is due to abdominal pelvic region injury, secondary other causes, and recurrent following treatment for the primary AACS. So generally, because of trauma, we all know that there is a CIRS and multi-organ dysfunction, edema, compression of the IVC. Ultimately, there is a ischemia to the tissues, which lead on to several problems. So when there is an intra-abdominal hypertension being measured, which is usually monitored once in 4 hours, pressure is measured. If it is a intra-abdominal hypertension, most of the time it's a medical management, which means we evacuate intraluminal contents in the form of a catheterized, put an nasogastric tube, or any space-occupying lesion within the abdomen, like bleeding, hematoma, etc., by minimally invasive or radiological, and improved abdominal wall compliance with adequate analgesia, pain control, and remove the constrictive dressing, and consider neuromuscular blockade, and optimize fluid administration, which had been discussed earlier, and always go for a goal-directed fluid resuscitation and do not over resuscitate the patient. When the pressure indicates that the patient has got acute abdominal compression syndrome, then sometimes we may have to intervene, reopen, and maybe consider corrective measures should be done, and manage an open abdomen. So missed injuries had been dealt earlier, had been discussed, like diaphragmatic injury or a retroperitoneal structures, or sometimes the structures which cannot mobilize, like a gastroesophageal junction, pancreas, or the stomach. There, the missed injuries can happen, and we may require subsequent laparotomies. Here, the pancreatic injury, where there is a transaction of the neck of the pancreas, which was missed. So always when a damage control surgery is taken, you have to go into the lesser sac, look at the posterior wall of the stomach and the pancreas, make sure we are not missing any pancreatic injury. Again, this particular patient came with some 12 stab injuries in the abdomen with the 24 stab in the intestine. So the anti-mesenteric stab here can be very missed easily. On the dreaded complication, the sequelae of the damage control surgery is obviously infection, like any other patient in the ICU. ICU infections are common, and more common maybe in this particular patient. And one rare problem is a fungal infection, particularly when there is a contamination. Here's a patient with evisceration of the bowel. You can see the amount of mud in the wound, pelvic wound. So this can lead on to the infection. Later, the patient developed a mold in the wound. So fungal infections can be problematic. So the study which looked at 344 patients, the complications reported had been about 25% of the complications were wound related. Rest were abdominal wound infection, abscess, and fistula. So different techniques of abdominal closure have been discussed. One is a Bogota bag. If you look at the mortality rate between the mesh repair or a vacuum assisted closure device, mortality is somewhat similar to all the cases. And the intracutaneous fistula rate is slightly less with Bogota bag or with a vacuum assisted closure device. So these are the devices which are used. This is an open abdomen, which can be closed without any mesh with abdominal release incisions. And sometimes if you can't close, you can use a skin graft and then plan for a definitive incisional hernia repair later. So this is the incidence of, in this particular study, a wound infection. Sometimes the superficial wound infection, you can leave the abdominal wound because majority of the time this wound is going to get infected, which can be secondary closed, or if left alone, they will close again. The nightmare is the intracutaneous fistula following a damage control surgery. It's extremely difficult to manage, and it's best to prevent the intracutaneous fistula. These fistulas are basically can be prevented if you plan for an early abdominal closure. Do not leave the open abdomen damage control surgery for a longer duration. Plan to close the abdomen early. Bowel coverage. Try to cover the bowel with a momentum, or in case it's an open laparotomy, use some plastic sheets or the latest vacuum devices, which has got a non-adherent sheet. Those intestine will not adhere, or at least close the skin. And try to avoid the deep burying of the intestinal anastomosis under the bowel loops, thinking that this will prevent leak. So once the fistula happens, it has to be managed. It's a tailor-made depending upon the patient general condition, nutritional status, or the comorbid condition, and the anatomy of the fistula, where it is located, and whether it's a high output fistula or a low output fistula. The most important component is the nutritional management, where the patient may be put on long-term TPN till the fistula settles down, and other aspect is the infection control is very, very important. So the wound management again is very, very difficult. One has to control the effluent which is coming from the wound, and you have to separate the wound into different compartments and manage. The best ideal would be the negative pressure wound therapy, and definitive management of a fistula has to be delayed till the wound is healed, completely healed, and the patient is nutritionally and metabolically is much improved and can withstand the surgery. So this patient, you can see this is going to be a nightmare here. The patient is very nutritionally debilitated, and you have an open abdomen, fecal command. Here you have to apply all the principles and then take care of the nutrition, take it slowly for the definitive closure of the fistula. Another patient who had a definitive closure and later on developed in his fistula on the drain side. This is much easier to treat because the patient is well nourished and the wound, everything is healed. Now you can do a laparotomy, and this is the small bowel where the anastomosis was done, and this was a fistula. Now you can do a definitive resection and anastomosis and take care of the fistula. Now, intra-abdominal abscesses, the incidence vary between 10 to 70%, and the reasons being the packing. If you leave the packing for a longer duration, more than 48 hours, there's likely that patient can develop intra-abdominal abscess. And obviously, in a septic abdomen, there's a chance of tertiary peritonitis, and the small bowel leak either maybe because of a missed injury or because of the anastomosis. And whenever a patient with a damage control surgery and who has an unexplained fever is not improving, suspect there could be an intra-abdominal sepsis. Always the gold standard would be to get a CECT abdomen, and the management will vary depending upon where the abscess is. Either it can be controlled radiologically, or when the abscess is accessible to the radiologist to put in the drain, or minimally invasive or maximally invasive. This is an example of a patient with damage control with a pancreatic injury with a necrosis, which was delayed laparotomy, and the necrosectomy was done. Ultimately, the patient was sent home with a drain, and he developed subsequent abscesses. He required nearly 4 laparotomies and debridement of the pancreatic necrotic tissue. Ultimately, the patient improved after 2 months' time. And radiologists are very helpful. They can drain a loculated, accessible abscess, putting in a drain that makes the surgeon's life much easier. Or sometimes after a liver injury, patient may develop a bilioma, which can be aspirated, or sometimes a minimal invasive surgery can come into play. Here is a patient with a diaphragmatic rupture with a stomach rupture with a lot of food particles in the chest as well as in the stomach. And the subsequently patient developed abscess around the liver, and through the drain, laparoscope can be put in and can be accessed when radiologists cannot help. This is a possibility in limited cases. Again, the wound dehiscence is a nightmare. So if there is no associated infection, it's easier to manage. We can do a closure if it is a very small defect. If there is no infection, and there is no bowel problems or a leak or a sepsis, then sometimes you can use a mesh repair augment with a facial closure, or plan for a later closure with just closing the skin and later hernia repair. When there is an infection, you have to address the infection. If there is abscess, drain it. Necrotic tissues should be drained. And if it's a small defect, you can close it. If it is a very large defect, in the infected scenario, it's best to manage with an open abdomen and with a vacuum assist device. Thromboembolism is obviously a higher risk for the patient, particularly sometimes a trauma to the abdomen, like a blunt injury or a penetrating injury, can itself cause a thrombosis, or high-risk patients like pelvic injury can develop thromboembolism like DVT and vascular repair. Here is a small bowel gangrene. The patient had resection anastomosis, but later, again, during the third laparotomy, there was a segment of ischemic bowel, because this patient had a blunt injury abdomen with the thrombosis of the the splenic vessel and the portal Again, this has gone in for embolus to the segmental vessel of the bowel and needs to be resected the subsequent laparotomy. And then sometimes the vascular injuries, we may have to ligate the vessels. What are the complications if you ligate the vessel? If you ligate the celiac axis, there's nothing much to be worried. Similarly, splenic artery, provided the short gastric vessels are intact to protect your fundus of the stomach. Common hepatic artery, nothing to worry, provided the portal vein is intact. Possibly a gallbladder ischemia, so we may have to remove the cholecystectomy. Superior mesenteric artery vein, the possibility of a bowel ischemia, which I've demonstrated in the previous video, and portal vein, again a bowel ischemia, suprarenal IVC, possible renal failure, inferior vena cava, the lower extremity edema is a possibility, so you have to elevate the leg and assess for the compartment syndrome in the lower extremity. Left renal vein, nothing to be worried about. Right renal vein, right renal ischemia, sometimes a nephrectomy may be needed. Common and external iliac artery, lower extremity ischemia, which may require fasciotomies, and then vein, again, lower extremity edema. And if it is an internal iliac vein, nothing to be done. Here is a patient with a bulgur injury. You can see inferior vena cava injury, as well as the right renal injury, which is being approached during the damage control surgery. The rent in the IVC had been visualized and the clamp had been applied, and the suture of the rent in the IVC had been done, and patient also had a right nephrectomy. And you can see after the completion of the vascular suture, that is the IVC, where you can see there's a narrowing of the IVC. This patient can develop lower extremity edema. Luckily, this patient didn't develop any extremity edema. So, ladies and gentlemen, sequelae of the damage control surgery is sometimes may be urgent or may be delayed. Sometimes you'll be faced with many unknown. So you should have various options and require a deliberate plan and should be flexible and persistence in treating these patients. And you should have a good stamina managing these complications. And you should have a high level of judgment and skill. You have to take care of the patient, lead the team. And the most important thing nowadays with the medico-legal issues is communicate effectively with the family, get a proper informed consent. If possible, get a video consenting as well. Sometimes I do call the patient's relative inside the OT to show them the extent of the injury, because we live in a periphery. The entire village will come in and will have a lot of problems when a patient, particularly young patients, are being brought to, with a trauma and dies. So recognize our own limitations and get help wherever possible. And thank you. I would like to thank the trauma team as well as the trauma for the opportunity. Thank you.
Thank you, Dr. Rajshekhar. That was a wonderful talk. I think your photos and videos were very impressive.
Thank you. Thank you, sir.
Can we take the questions, Dr. Girish?
Yes, sir. Yes, sir. Please go ahead with the question, sir.
Dr. Mohan?
Yes, sir.
There are two questions for you.
Sir.
One is, what is the role of cryo in DCR, damage control resuscitation? Hello, Dr. Mohit?
Dr. Mohit, you are please unmute yourself.
Yes, sir. So I appreciate this question, sir. The role of cryo is still evolving and still it has not find its place in the initial resuscitation of trauma patient. Now, this may be because of maybe resource allocation and problem with having cryoprecipitate, because for making 1 unit of cryoprecipitate, we need at least 10 units of FFP. Numerically speaking also, so the amount of fibrinogen which is provided by 6 to 8 units of FFP, which is anyhow will be given in a patient of massive hemorrhage, will provide nearly 2,400 milligrams of fibrinogen. And this is sufficient for coagulation in a patient who we considered even afibrinogenic following trauma. So, sir, this may be one reason why this is not being used, numerically speaking also, by resource-wise also. But it may be so that with like coming evolving evidence that might find its place, it might find its place in the resuscitation in the coming years.
Thank you, Dr. Mohit. There's one more question. That is, you mentioned that it is 60 to 80 ml per kg per hour. So there's a question whether it is a lot of fluid, like
Right.
if it's
I
70
accept
kg.
that kg should be kind of is a typographical error. The whole idea is to provide initial fluid boluses in the aliquot of 100 to 200 ml initially, and to see the patient's response to it. Just to maintain the systolic blood pressure somewhere between 80 to 90 in blunt injury, and maybe like 60 to 70 in case of penetrating injury.
I think so. Therefore, I think the message is that should be tailored to every patient, every
Right.
individual.
Right.
I think that's the message.
Sir.
Do you have any experience with TEG at your institution?
Yes, sir. We do have TEG and ROTEM, and we resuscitate the patients based on the TEG reports.
And do you find it very useful?
Yes, I showed that in my presentation also, the TEG machine we have. And definitely, we can be more wiser in using the blood components based on TEG.
Thank you.
So
Is there any role for hypertonic saline? Nobody has asked this question on the chat box, but what's your opinion?
So at present, we are not using it. We are definitely not using it. We are using just crystalloid initially, followed by early use of blood and blood products. We are very liberal in that. Yes, you are right in saying that there may be some role of hypertonic saline. It has been studied, but then still it has not been tested with time, and it doesn't have any place in routine resuscitation of patients.
Thank you. Is there any role for whole blood, according to you?
And that's again is evolving. So I think we are just going to the
it's a full circle.
Past again, yes, sir. When initially it was started with whole blood, we came to blood components. Probably the emerging evidence is yes, we go back to whole blood again. But as of now, in practice, definitely we are using blood products in the ratio of 1:1:1, and probably again this may be an inciting thing as to why we are using this blood components, which ultimately makes one whole unit of blood.
Yes.
So that may be the understanding. Probably in the coming years, we may just go back to the previous years.
Correct. It's a full circle which comes back.
Right, sir.
Thank you. Dr. Subodh, there are two questions.
Yeah. So before you ask me, can I just make a comment?
Yes, sir. Yes.
So as far as the Mohit beautifully described the blood pressure in blunt and penetrating, I just want to add, as long as your kidneys are perfused and patient is producing urine, I think that is the key about the permissive hypotension and balanced resuscitation. So if your patient is producing urine at 70 mmHg, I'm happy. If he's not, then I will raise the blood pressure to 80 and I would like to see the urine. This is one. Second comment about the whole blood is that, yes, it's a full circle, but the problem with the whole blood will be that we have to test it, right? So we cannot give like in Bollywood movies that one is donating and you are transfusing it on the other bad. So we all know that it should be tested for HIV, HBsA, GS, hepatitis C and all. So that is the main constraint with the whole blood, and you don't find donors in India. The moment you ask them that your patient requires blood, so and it is a very good tactic we use. If there is a lot of patient attended with the patient, we ask them to donate blood, and everybody will vanish. So I have my doubts about the use of whole blood in near future in India. Yeah.
So may I just add something to what you already said, if I'm allowed?
Please go ahead.
Sir, regarding those fluid volumes and the blood pressure, one shouldn't take it sacrosanct because it will differ from one person to other. So we as a surgeon, we are very rigid that, okay, like it has been said that we have to keep the blood pressure between 80 to 90 and between 60 to 80. Now, these are just initial guides. We shouldn't take them as kind of strong, rigid things. The thing will change from one person to the other. The whole idea is, and the thing which comes out from it is, we shouldn't be overzealously, giving fluids to raise the blood pressure to normal or supranormal levels. That is the message. Those values, they are just initial guide. That is, this message shouldn't go wrong to the postgraduates and the other persons in the conference.
It's the physiology that you're looking at and the end response of the patient.
Right. Right.
More than the actual volume or the number. Dr. Subodh, there's a question from Dr. Vijay.
Yeah. Please.
Regarding judicious use of damage control laboratory, because nowadays there are some reports that it's been overused. So there's a question for you about your opinion.
My opinion is, number one, that if you do not have facility, the damage control laparotomy is a part of the damage control resuscitation. And I'm glad that he asked this question. So if you do not have the facility to manage this patient just for the sake of doing laparotomy, please don't do it. So if you cannot complete the algorithm of damage control resuscitation right from the ED till the definitive laparotomy after the ICU at 48 hours or 72 hours, do not take the patient for damage control laparotomy. This is one message. It's better you transfer this patient early to a facility where he can be better taken care of. This is one message. Second is that if you have to do damage control laparoscopy, and I showed in my slide that live problem is better than a dead solution. The patient should qualify, and I showed a list during my presentation that who are the patients who will qualify for damage control laparoscopy. And if your patient is a non-responder and he qualified to be taken up for damage control laparoscopy, you should not hesitate. And I'm sorry, Dr. Rajshekhar, you should not hesitate for complication associated with damage control laparotomy, because your immediate concern is to save his life.
Thank you, Dr. Subodh. I think that answers Dr. Vijay's question. Dr. Vijay, would you like to say anything? You have to unmute yourself.
Yeah. Okay. Thank you, sir. Thank you for a wonderful presentation on damage control surgery.
Yeah, Dr. Rajshekhar, there is one point about the cost, particularly after complications of damage control laparotomy or after damage control surgery. And that is something which hits patients in the private setup. In a government setup, probably it doesn't matter, but do you have any comments about this?
It definitely cost, comes with the trauma patient. So that's why I said, every part of the treatment has to be discussed appropriately with the relatives. From the beginning itself, you have to tell about the cost, how much it's going to be, and you don't guarantee any outcome, and you have to, project the cost for the worst scenario. Otherwise, we'll land up with problem. It's not good for the patient as well. Halfway through the patient, relatives cannot afford treatment. They have to shift to another center. For that, from the beginning itself, once the patient had been resuscitated and can be shifted to another government setup, definitely cost is a matter in these sort of cases.
Thank you. And I think you brought out the issue of medical legal problems, because, with repeated surgeries and a sick patient, probably documentation is something very important in these patients.
Extremely important.
As to why you did the damage control in the first place. And therefore, what was as Dr. Subodh said, what were the indications? That needs to be documented and communicated to the relatives. So I think, Dr. Girish, we've had a wonderful session with 3 wonderful speakers, and I'd just like to thank all of them. And on behalf of Traumasicon, and on my own behalf, I'd like to thank the organizers for permitting me to chair this session. Thank you very much. Back to you, Dr. Girish.
Thank you very much. Thank you.
Thank you, sir.
Thank you very much, Mohan sir, for conducting an excellent session with all the stalwarts of trauma, giving their knowledge and sharing with us. We have all gained, I think, all of us who are dealing with trauma and all the delegates who are there, they would have gained by their talk, their experience, and they have shared their own experience. That is great. And we end this session and we come to the conclusion of day 1 of Traumasicon 2021. I would like to thank Mohan sir, who chaired this session. Dr. Veena, can you share the slide of thanking Dr. Mohan, please? Veena, are you there?
There are a couple of questions on the chat box, which maybe they can address on their emails and get replies.
Yes, yes. There are certain questions which they can be addressed on their this thing. I would like to thank Chairperson Dr. Ellen Mohan sir, who conducted it very well. Thank you very much, sir. I would like to thank all the. Thank you very much, sir. I would like to thank all the speakers of today's sessions, all the chairpersons who made today's day 1 as a great success. And one announcement to all the delegates that they tomorrow's conference sessions, which will be shared with you on your emails. So there will be a separate link. This is for information of all the delegates and faculty. Thank you very much and good night. Veena, can I leave now?
What
The
time
event
tomorrow, sir?
management team.
What time?
Tomorrow
What?
6 o'clock. No, same. The session, the timing is same actually. It is only the link you will be sharing with them, right?
Okay.
Tomorrow at 6 p.m. Same timing. Timing is the same as per the schedule. Only thing is the link will be different.
Thank you, sir.
Okay, Dr. Reshma, I think you asked me that question. Yeah.
Yes, sir. Thank you.